Thank you. Could we start the live stream, please? Thank you very much. Well, good morning, members, ladies and gentlemen, and guests and officers. We're at the Health Scrutiny Committee this morning, and we will first of all just check that everybody agrees with the minutes from the last meeting on the 8th of June. Do I have anybody that wants anything altering? Everybody happy? Thank you. Apologies for absence, please.
Thanks, Chair. We have apologies from Councillor Barney on medical reasons, with a substitution from Councillor Jonathan Wheeler. And we also have an apology from Councillor Maggie McGrath, who's on leave, and Councillor Errol Henry is substituting for him. Thank you.
Thank you. So welcome to those members assisting with this committee this morning. Thank you. Declarations of interest. Disclosable pecuniary interests. Anybody? Yes, Councillor Bailey.
Hi, I just want to declare that one of those consulting on the Basildore Hospital was Brendan Clark-Smith, who's my employer.
Thank you. And I will give a personal interest as my daughter works at NUH. Anybody else has anything? No? Right. Private interest. Do we have any private interests? I hope you're all interested. Let's put it that way. Okay. Right. So we're moving on to the first issue, agenda item number 4, which is the Basildore mental health engagement and proposals. So I'd like to welcome Idris Griffiths this morning, who is the Chief Officer of Basildore CCG, and Julie Atfield, Executive Director of the local mental health services, to our Health and Scrutiny meeting this morning. I must give my thanks to Julie, who looks a bit different from when I saw her a week ago. She's had her hair cut. So thank you to Julie for allowing Councillor Glyn Guilfoyle and myself to visit the inpatient mental health wards at Basildore Hospital last week, a week yesterday, in fact. And we both found that visit extremely valuable. So thank you, Julie, for that. The committee are looking forward to hearing your plans about the engagement and decision-making process that you have undergone with regard to the proposals for the mental health services in Basildore. However, I am disappointed that the committee haven't had access to all of the material that will go before the CCG governing body. I'm referring to the full analysis of the engagement and the precise terms of your decision making. I do appreciate that the papers for your governing body meeting are only published today. However, it would have been useful and totally appropriate for the same information to be given to us in advance in order to allow us to do our job, part of which is making a judgment on whether the proposed changes are in the interest of the local health service. If you are ever in a position of presenting to us a substantial change like this again, I would encourage you to do so in such a way that the Health Scrutiny Committee has the same information as the decision makers. This is strongly in your interests, allowing us a better understanding of what you have planned, as well as preserving the excellent working relationship which we enjoy. So with that said, over to you, about Idris and Julie, and so that you can explain to us exactly what you have in mind. Thank you.
Thank you, Chair. Perhaps I can first pick up your point with regard to the information. And I agree that it is unfortunate that we weren't able to share the full sort of business case and information with you this morning, or indeed prior to the meeting. The papers for our governing body are issued by close of play today. The meeting is next week, so it's a week in advance. None of my governing body members have seen the paper to which we refer. I signed off the draft last night, so it is very much sort of a document that wasn't available. And I think that is unfortunate, because I would have preferred to have been able to make that available to you prior to this meeting. But of course, our governing body meetings are set in the same way that council meetings are. And I think it's just a question of timing. So apologies for that, but it was unfortunately unavoidable. What I'd like to do, though, this morning is do a short presentation. And I know councillors will be very keen to sort of ask questions and to make comments on the proposals. But hopefully the presentation will set out both the context and sort of the reasons and all the key issues that we are considering and that my governing body will be considering as part of its decision-making process at its next meeting. I'll do a short introduction and context from a commissioning perspective, and then I'll hand over to Julie to describe the current services as they stand and the issues that we currently have with those. And there will be focus on the inpatient beds, because I think that's the sort of the most challenging and perhaps contentious part of the proposal. And then what the potential solutions for those are. And then I'll come back in to give a little bit more information about the decision-making process, what we'll take into account, and the next steps. So I think you've got hard copies of the presentation. And if we go on to the next slide. So from a clinical commissioning perspective, we have set out a mental health strategy and a commitment to do our utmost to meet the mental health investment standard in its entirety. We wish to improve community care for mental health services. This is part of the public engagement exercise that we've carried out. We want to support people in providing better self-care and indeed improve the quality of the facilities in order to provide the best possible hospital care, of which we'll be talking about in much more detail. And generally, therefore, improving the personal health and well-being of the residents of Bassetlaw. Obviously, from a CCG perspective, our focus is on Bassetlaw patients, but as we'll see from an inpatient facility, it is very much a Nottinghamshire facility, not a Bassetlaw alone facility. So I very much welcome sort of the opportunity to speak today at the Health Scrutiny Committee on a county level, because actually the patient flows are such that it affects more people in the rest of the county than it does actually in Bassetlaw. So I welcome the opportunity to speak on this as a county-wide perspective. The next slide says our aims over the next 3 to 4 years. I'll just sort of run through those. There you go. So when I talk about investment in mental health services, we're actually talking about roughly £4 million over the next 4 years. That investment goes entirely into Bassetlaw-based services, but there's quite a range of those. So we wish to invest in local community hubs supporting both physical and mental health and with the voluntary sector, services that were wrapped around individuals. And we want to establish with Notts Healthcare the no wrong door approach. So wherever a patient presents with a mental health problem, that they will be able to get the right sort of support tailored for their needs and not be sort of bounced around or passed around, as sometimes has historically been sort of the case. And I think in the health service, we recognise that we sometimes struggle with the various specialist sort of services that we provide, and sometimes having to go the patient going backwards and forwards before they get their care. So we are committed to addressing that from a mental health perspective as part of this investment. And of course, the money that we are investing means an expansion of services. We've identified particular areas of need. They include, but not restricted to, perinatal care, so care for new mums, and in particular for children and young people. And I think this comes at a time of great challenge and great need. So the implications of COVID, both during the pandemic itself, but even as we look forward to the coming sort of years, the impact that it will have had on vulnerable people, and in particular children and young people, I don't think can be underestimated. So this investment comes at a very significant and opportune time. Our IAP services, which are actually provided by a different provider, have coped extremely well throughout the pandemic and continues to meet most of the targets we have in waiting times and so on. But we wish to invest further because the talking therapies have been particularly important, I think, in addressing a wide range of mental health needs. The crisis service and severe mental illness service is really important because when we look at the inpatient facility, actually that's a relatively small part of that sort of immediate response, both linking to A&E, supporting people to remain sort of in their own homes and often sort of with the support of their sort of family and friends. And so additional investment is being targeted in Bassett Law for those areas as well. And unfortunately, and again linked to, I think, largely some of the impacts of COVID, we have seen an increase in things like eating disorders, but also in self-harm and drug and alcohol use. So if we look at the inpatient services, I suspect that's going to be a large part of the conversation, but I did want to put this in the context that we are not reducing services. We are not reducing inpatient services, we'll actually be increasing them. But far more important, I think, in terms of the thousands of patients that receive sort of care and support from Notts Healthcare, that will all be related to the £4 million of investment in Bassett Law for Bassett Law patients. But why do we want to change? We want to improve access to additional mental health and therapeutic and recovery services. And we recognise that that's not as easy as it should be because the wards are isolated from the other specialist services. And indeed, for some of the more specialist cases, patients have to be admitted to other hospitals rather than Bassett Law. So that's already the case. We don't have the scale to be able to wrap around the specialist support that older adults and adults that receive inpatient care really require. And the experience, for reasons that Julie will go into more detail about, is really far from satisfactory. And that is not the result of the staff or the service, it is the physical facilities that we have. But also clearly, similar to the County Council, we must use resources to the greatest benefit to the greatest number of patients. And as I've mentioned, the patients who receive care in the community and crisis services and so on, IAPS and so on, that's many thousands of people. The wards in Bassett Law are relatively small and relatively small numbers of patients, but it is important that we are able to provide the best care possible, and that is our clear intent. And I'll hand over to Julie, who'll give us a bit more information about the current services, in particular the inpatient services, and the potential solutions to address those. And then I'll come back in to talk about decision making and next steps.
So, just to give you a sense of the provision at the moment at Bassett Law Hospital. So we have 39 beds on 2 wards. The wards located there in the late 1980s after the closure of Saxondale Hospital. At the time, they were. It wasn't uncommon to relocate mental health wards onto what were general hospital wards. And over time, obviously standards and expectations around what the care looks like in a facility like that has actually changed quite considerably. Other services have often moved to specially built accommodation. And some services still remain in sort of old general hospital style accommodation. The Trust, in relation to this, moved its inpatient services out of the Queen's Medical Centre about 5 years ago and moved them to Highbury Hospital. And in the same vein, the Trust had a new purpose-built facility at Millbrook in Mansfield, which members are probably familiar with. So the Trust has got a very mixed provision in terms of accommodation. The services at Bassett Law Hospital, there are 2 wards. We have B1 ward, which is a facility for older people. There are 15 beds, and we split that facility for people who have a functional illness, who are over 65. So that's people who are probably depressed or maybe have psychosis. And we separate people with dementia on the same ward. On B2, which is our service for adults with mental health problems, we have 24 beds on that ward. We don't usually open all of those beds actually because the environment is quite cramped. So probably for the last 2 years, due to the constraints in the environment, we've not actually had all of those beds open because of some of the environmental constraints. And that has been probably exacerbated, obviously, by COVID over the last year. Both wards do have dormitory accommodation, 5 beds, separated by curtains, and the dormitories have often shared bathing facilities. It is out with modern expectations around the facilities that are provided. We don't obviously mix dormitories at all. Male and females are kept totally separate, and we always work really hard to maintain people's privacy and dignity in that environment. But nevertheless, it doesn't meet modern standards in terms of regulations, particularly from the Care Quality Commission. And they do have expectations upon organisations to eradicate dormitories. So people like me are often posed the question of what is your organisation doing to eradicate dormitories in its inpatient population. So that's one of the reasons why this issue is on the table today about the standard of the accommodation. The services will show you a bit about where patients come from and the issues about how people's pathways work. Sometimes patients from Bassetlaw do choose to not access the wards at Bassetlaw, but do choose to go to Millbrook and on occasions go to Highbury Hospital in Nottingham. And at the same time, there are patients with particular needs as well that we don't admit to the wards on B1 or B2. So say somebody needs psychiatric intensive care, we wouldn't normally admit those patients to Bassetlaw because it's the environment's not sufficient to maintain the level of care that they need. There are lots of professional recommendations about inpatient services, about ward size, and about types of patients and how you accommodate patients of different age groups. It's not, over the years, been felt to be appropriate that older people, particularly frail people, obviously share wards with younger, perhaps more psychotic patients. So that's an issue for us in this facility about keeping those groups separate. Also, the wards are mixed gender. Again, we work very hard to make sure that we protect people's privacy and dignity, but nevertheless, at the moment, the wards have patients of both genders using the same areas, and we have strived hard to manage that, but it is extremely challenging, and it doesn't meet the requirements as we would want to see them. The wards are on the second floor, so that's tricky in terms of access to fresh air, access to people with disabilities, and visiting and families. So I'm sorry, that does give you a sense of the sort of physical issues that we've got with the building. And I know the chair did take some time to visit to see some of that. So we'll talk a bit more about the patients who are using the facility, but that gives you a sense of what the current provision looks like. I don't know whether you want to cover this, Idris, or me. We've both, well, over the time, we have actively reviewed the patients using the facility at Bassetlaw. So in the last full calendar year, I think we had 101 Bassetlaw admissions to B1 and B2. And the beds actually on the wards were then overwhelmingly filled with patients from the city and the county. So the demand from Bassetlaw patients is roughly a third of the use of those beds. So you've got a third of the wards with Bassetlaw patients, and then the rest of the patients are made up of the county and city. In Nottinghamshire, we do, as a trust, we manage the beds in their totality. So we wouldn't leave empty beds at Bassetlaw and send patients out of Nottinghamshire for care. So we do use the remaining beds for all of our patients and to their benefit. And that has been a challenge to us in Nottinghamshire, but we've made massive strides, and we don't send people out of the county for inpatient care unless it's absolutely necessary. And that's a much rarer event now than it ever was. In terms of the occupancy, so if you look at the totality of the available bed days on B1 and B2, it's 37% of those that are used for Bassetlaw patients. So I think that's an important thing to bear in mind. I don't know if Idris, you want to add anything to that?
Just really briefly, because the chart in front of you describes Nottingham and Nottinghamshire CCGs versus Bassetlaw CCG. If you go underneath that, as Julie's just said, the majority of the patients are actually from Nottingham City, and then the patients from Mansfield and Ashfield are broadly equivalent to those from Bassetlaw, and then you've got a spread of others throughout the county. The vast majority of patients, therefore, are inpatients from Bassetlaw, are from the county. Very few come from outside of Nottinghamshire and Nottingham, but the majority, as Julie's just said. And in fact, if anything, it's a reducing proportion. So it was about a third, and actually in the last 12 months, it's probably been about a quarter. So, you know, it's just important, I think, to get that understanding, particularly when we talk about the potential solution for this. And one of the options, obviously, that is being put forward is the facilities in and just outside of Mansfield, which is actually nearer to where most of the patients actually come from who are currently admitted. So just getting that perspective, I think, is important.
So, and a focus on Bassetlaw patients. There are about 101 admissions a year of Bassetlaw patients to B1 and B2. And their length of stay for the older adults is about 45 days, and for the adults, it's 32 days. So it's just a bit of a sense about the numbers of people coming and how long they're staying, which is particularly important if you're thinking about making any changes to people's pathway and provision, about the numbers of people that we are considering to be impacted upon. So, thank you. So over 2 years ago, the Trust and the CCG started to consider several options to do something about the challenge, particularly of eradicating dormitories, and the challenges and issues we know we've got clinically on the wards in Bassetlaw. And there were a number of considerations taken into account. No options were off the table, and the process that we worked through considered a full range, and a range of expectations about what we could hope to provide locally, and some of the issues around that. So we considered a new building Bassetlaw. We also considered leasing accommodation, perhaps in partnership with another private provider even. So all of the options were absolutely around, you know, leasing space or sharing service facilities. And we also, primarily with the CCG, there was the consideration about arranging a subcontract and re-tendering the service and contracting the capacity in the service from another provider. We also looked to consider the rest of our estate and the potential that was available. The Trust was in the process of purchasing Sherwood Oaks at Mansfield. Sherwood Oaks is a former low and medium secure hospital on the outskirts of Mansfield. Before we acquired it, it was owned by the private sector. It wasn't in full use, and they chose to divest themselves of that facility. And given the challenges that we were facing as an organisation, there was definitely the potential to certainly help to eradicate dormitories, although we particularly focused at the beginning with the Mansfield, because we've got issues in Mansfield with Millbrook having dormitories as well. So primarily, Sherwood Oaks was there to address the Mansfield issue, and also it had the potential to provide more inpatient beds for us, which will help us address the challenge of not sending people out of area for their care. So what we have is the option as well to reconfigure the services at Millbrook for older people, whilst we have the opportunity to renovate Sherwood Oaks to make it an exemplar facility for people who are acutely unwell, where they can go and experience a therapeutic inpatient stay in an environment that's specially designed and modified to address certainly the privacy and dignity and safety issues for patients. I've worked a lot of my career in inpatient services. I'm a nurse by background, and I've seen the impact that some of the limitations of the environment and the way that we arrange services can have on patients and patient care. So as an organisation, and as an individual and a professional, it's a fantastic opportunity for us to improve care for people when they are most vulnerable, and they can have access to proper ensuite facilities. Things like OT, physio, visiting suites for their families, outside space which they can access directly off the wards, all of those things, and cared for with people with similar needs. I think we were keen to look at all of the criteria for all of the options in terms of the quality, how to meet national standards, the accessibility of the service, which we'll come on to talk about. I'm sure Idris will refer to that. But also the quality of the environment and how we manage the services across Nottinghamshire as a resource. We felt that the option of using Millbrook for older people as a specialist older people's hub for mental health, also located on a general hospital site, and then using Sherwood Oaks to its fullest potential to provide adult inpatient services. Thank you. So the proposal that we favoured was to provide specialist services on these two sites. So Sherwood Oaks would provide 2 female wards and 2 male wards. They all have single room ensuite accommodation. They all have, or they will have, we're in the stages of plastering and building, but they will have really high quality therapeutic environments. One of the things that's really important, particularly at Sherwood Oaks, is something that we call a line of sight. So when you're on a ward, you might not appreciate this going to visit somebody, but the nursing staff particularly like to see as much of the patients that they can, you know, particularly during daytime hours, really easily, and have really good lines of sight about where patients are. So those areas are really well designed with those features to accommodate that, with access to outside space and so forth. And then what we would have at Millbrook Hospital, which would be our mental health services for older people's hub, we're really keen to have this as a specialist facility for older people. We do care for people who are perhaps in need of more care, and particularly people who can't be managed, for example, in nursing and residential care, people who need specialist support around their mental health. So again, we're able to redevelop the environment. We're really keen as well to co-locate Age Concern and other third sector organisations with us, so that we can wrap around better the services for older people. So our plans for Millbrook do absolutely match those for Sherwood Oaks in terms of the quality of the facilities. Thank you.
Yeah, thank you, Julie. So I'll try and speed up a bit, because I'm conscious that I need to give you as much time as possible for sort of questions and comments, but just very quickly to run through. So the decision-making process is broader than the engagement, although that's a central part of it, and therefore I'll talk into a little bit more detail about that. But there is a process that, as a CCG, we go through with NHS England and Improvement, where they test, you know, sort of the service change and the proposals against a range of measures. We've consulted with the Yorkshire and Humberside Clinical Senate in terms of the clinical model to obtain independent and objective sort of views on the potential new model of change for the inpatient services. Obviously, we've come to yourselves and the previously constituted committees way back in September and then December and now, and that's to really go through sort of the range of issues that we've been describing today and what the plans for those initially were. Our governing body will make a final decision on the 20th, that's its intent. And then we are absolutely committed that if the change takes place, and obviously I've talked about the £4 million investment, and that will take place, we would be absolutely committed to post-decision feedback engagement, and not just, you know, sort of as a one-off, but on an ongoing basis. We very much feel that the wider the engagements of stakeholders around the future mental health services, the better. Moving on, so the first phase was a pre-engagement phase, really to look at the potential scale of options that we were considering and to engage with various partners about their views, and in particular how they recommended we conduct an engagement exercise. And the Health Scrutiny Committee was a pivotal component of that in terms of how we moved forward through this. But we've also talked to elected representatives of the District Council, to Health Watch, to Bassetlaw Community Voluntary Services and others. So during the engagement phase, and this we extended this to make sure that both during COVID and because of the winter, that people had the maximum opportunity. Like I said, the potential change has now been described for just short of a year. So the engagement exercise, which we conducted in a variety of ways, particularly to get over the challenges of COVID. So we had an extensive survey that we conducted. We had various consultative meetings with stakeholders, but most importantly with carers and patients. We conducted a controlled representative telephone survey, which captured the views of over 500 additional residents. And then the targeted consultations, and there was information put out in social media. There's dedicated information on our website with the opportunity to respond to that. I'd also say that we've got, just coming to the next slide actually, Martin. So just in terms of the scale of that engagement, we've had well over 900 sort of individual responses, but one of those was also a petition against the change in the inpatient beds that attracted nearly 2,500 signatories. And the common theme that's come out of this is that, broadly speaking, about 85% of the respondents are very supportive on the investment proposals and for the areas of priority. But the recurring area of concern is the travel and accessibility of the inpatient beds. Just move to the next slide. Thank you, Martin. So we recognise, sort of that as an issue. It's not an issue for everyone, and as we've described, almost as many patients actually come to Bassett Law Hospital inpatient beds in Mansfield and Ashfield as they do from Bassett Law, and the single largest proportion of patients overall come from Nottingham City. So we found that where people were responding to the engagement exercise from outside of Bassett Law, they didn't express the same level of concerns. And I think we're more sympathetic to the aspiration of, as Julie's just said, of creating exemplar facilities really for patients on an inpatient perspective. But of course, it is a change for people, and for the up to 100 people per year from Bassett Law that are sort of admitted, there will be potential implications for them in terms of transport, and they will vary, and some will be impacted on more than others in terms of the convenience and their ability to access the new facilities, if that is the decision that is made. So we, as part of the final decision, I know my governing body will be very keen to be very clear about what the arrangements will be put in place in terms of support for transport, for carers, for relatives, and indeed for the patients themselves, not just on admission and discharge, but also in visits back home during the acute phase of admission, but also in particular the patients, relatives and friends, sort of that would want to visit. As we said, the inpatient stay is typically fairly long, sort of around about a month. So these aren't patients going backwards and forwards and things for short periods of time. They are relatively long lengths of stay. So that social contact is really important. So in terms of next steps, this is my final slide, and I'll open it up and pass it back to the chair. Like I said, we'll review the decision-making business case. That will be made available later today. As I mentioned just right at the beginning of my introduction, it is pretty hot off the press. I saw the first draft of the full document yesterday morning, and it has now been amended and finalised late last night. So we will be making that available today. Apologies again for the problem in terms of timing of these two meetings, in terms of being able to make that sort of fully available. I don't think there are any surprises in that document. It goes into a lot more detail, but I don't think there's anything in there that we won't have covered, both in the paper that we sent prior to this meeting, to the information that we've shared in terms of the engagement exercise and the presentation that we've given you this morning. Post-decision feedback and engagement will then roll through into end of July and into August, so we can really consult with people further in terms of the measures that will be put in place if a change in the inpatient facility takes place, because we want to work with people, particularly patients and relatives, in terms of transport and so on, if that is the decision that the governing body makes. And finally, I just want to assure the Health Scrutiny Committee that we will want to keep engaged with you going forward in the future as well. And if the change does take place, I'm very keen that you have the opportunity to be assured or to challenge whether the arrangements that we put in place to mitigate against the Bassett Law patients' higher level of inconvenience is actually successful and effective. So that is a commitment to ongoing engagement of this committee, and I'll close there. Thank you, Chair.
Well, thank you to you both for that briefing, and I'm sure all members of this committee are have lots of questions to ask. Just before I hand over to them, I appreciate the services in Bassett Law need to be updated. However, I believe local services should be for local people, and these proposed changes, in my opinion, have to be weighed against taking services away from Bassetlaw, which we all know once lost will not return. I know you have a problem with your lift. It keeps breaking down, but I do feel that there could be a unit either found or built in Bassetlaw for probably between 12 and 15 patients, which is what you say you have from Bassetlaw. And those people could be kept locally so that their relatives could visit them. I fortunately haven't had anybody in my family that have experienced mental health, but I would have thought if you have elderly parents who experience dementia, you need to see them daily, not rely on a transport system, which may or may not take place, which I think I've just understood from something you've said, that you haven't even got an idea what this is yet. Now, we all know that people will feel a long way away if they're taken to Nottingham and Mansfield. I can imagine an old couple, an elderly couple who lives, let's say, up in Harworth on the border. The husband may have dementia, the wife may be old and not able to drive. How will she get to Kingsmill or Highbury to see her relatives? And you talk about the money. We all know that in these times of difficult financial restraints, that we can be told the money's there, but if there isn't a legal agreement, then how long will it last? A year? 2 years? As soon as anybody gets short of money, they will say the transport has to go. There is no bus service that those people can get. They will be totally cut off. How does Mrs. Jones see her husband, who might be in Millbrook or Nottingham, Highbury? How does she get there? How often can she see her husband? These answers are not here, and neither can we see a sample of the survey, which I would have liked to have seen, and I'm sure everybody else would. And I think the transport is the biggest problem with this. I don't deny that. In my opinion, you need a smaller building that your local people can go to. And if they have to go to Highbury and Millbrook because they are more seriously disturbed, then I think that travel package wants to be very, very clear. Legal agreement, how long does it last? How often can people use it? We all know, I've had experiences, and I guess everybody in this room's had experiences where travel packages have been set up and within 2 years, I'm sorry, they've gone. The mental health services the inpatients will have gone from Bassetlaw. Your travel could well go and people are left high and dry. And I'm interested to hear what everybody else says, but this is the greatest concern to me. So, members, can I ask Councillor Bailey first, because he's a local member, and then you, John.
Thank you very much. I'd like to echo the concerns with respect to the transport and the survey sample. I noticed that you mentioned that social media comments, there were 12 responses. Just from my experience, there was an awful lot, all spread over social media. So I'm not sure how representative that is and what they said. But in particular, in terms of transport, for example, let's take up another example, Beckingham. I've just been doing some Google Maps prior to the meeting. So I believe it takes 30 minutes to go from Beckingham to Worksop at the moment, where Bassetlaw Hospital is. However, if you move that to Mansfield, that's an hour. So that's just car transport. If you don't have a car, that increases, I believe, to 2.5 hours just one way. And as we all know, if the buses don't run on time, if the trains don't run on time, that is going to make even more difficult. And if we don't have the transport links or the packages, you'll appreciate that that's a very significant concern. And in this document or this report, I don't see that being addressed. And really it is one of the most important things. So I would like to ask, will that be addressed? When will that be addressed? Another concern would be how extensively did you actually look into another building, for example, just for Bassett Law inpatients. As you mentioned, I believe it was just one paragraph mentioned that basically dismissed it. And I just want to make sure that you've actually explored all the options in detail, just to make sure we've covered all bases. I'd also like to pick up on the demand side of things. So I believe it was mentioned there will be a forecasting that there'll be a decrease in patients. However, if we look at throughout COVID, we know mental health has been an increasing concern alongside increase in population as well as an aging population in Bassett Law. I'm not fully confident in this forecast of reducing beds and the like. So I just like some clarity on that as well, please.
Thank you. Idris.
Yes, thank you, Councillor. So I'll try and take those issues in order, and I'm sure you'll pick me up if I miss anything. In terms of the social media messages, I think they were the direct messages. There was considerably more social media sort of activity, and I think you're absolutely right to point that out. In terms of transport, yes, absolutely. From a Bassett Law CCG perspective, obviously we commission services for Bassett Law residents, and that is a real issue and concern of ours. It will be a long-term transport plan. Of course, it will be reviewed because we want to make sure that it's effective. But the funding to support that, we envisage will be part of the overall change, and therefore will be recurring funding for the foreseeable future. I think in terms of transport, the plans that we've been looking at, and there is more detail in the business case because that is the area that has been highlighted as the greatest concern. The transport plans need to be wrapped around each individual. The numbers are so small that we're not going to start putting in new bus routes and all sort of standard practice. It needs to be wrapped around the individual and their carers and families' needs, and it will be. And that will be in place in order to be able to give patients access to their relatives being visiting, as has been described. And I agree that that is an essential component of their care and their recovery. So I'm equally keen on seeing that. I think try not to stroke straight into a utilitarian argument, but two things in terms of money and in terms of the patient flows. We have costed out with Notts Healthcare the refurbishment versus new build versus sort of taking over another facility. The costs range between 10 and 20 million roughly. And we do not have any capital to put investment in that. I'm delighted to say that Bassett Law District Hospital is receiving about £17 million worth of capital investment around their A&E and front door service, which will improve in paediatric sort of inpatient care as much as sort of anything. So there is investment going into Bassett Law Hospital, but to put this amount of money that I've just mentioned in for the sake of sort of about 100 patients a year, I think is disproportionate, and I think that's wherein lies the problem. But also, it doesn't support and help the majority of the patients who are not only being treated in facilities that really are substandard for the type of care they need, but also they're far more isolated than Bassett Law patients would be. So it's even further. I googled some of the travel times from Mansfield and Ashfield and from Nottingham and Rushcliffe and so on of the patients that are currently being admitted into Bassett Law Hospital. And there's greater detriment and greater number if you reverse it. But I think, like I said, at the start of this is I'm a Bassett Law commissioner, so I'll look after the Bassett Law residents. But from a county perspective, I think it is important to recognise that more patients are being inconvenienced to a greater extent under the current facilities than there will be in the proposed new ones. I think that's just an important point to get across. I think in terms of the patient numbers projected to decline, and we have seen by and large with an exception that we're looking into, a general decline in inpatient facilities, as we have had for many years. That doesn't mean to say that the demands on mental health care and the needs of the populations are reducing. Far from it, and that's why the £4 million investment in community and crisis and other based services are so important. But the better they are, the fewer number of patients that then require to be admitted as an inpatient, because that is an extreme event for a small number of people, and we want to try and reduce that as much as possible and support people to remain in their own homes. So that's where the £4 million investment comes from. That's why we anticipate a reduced number of inpatients in the future. Julie wants to add to that.
Yes, I think your question's right about what will the future look like, and it's something everybody's professionally debating, forecasting, and so forth. And no doubt there is the current impact and on people's mental health that we do see. I often don't forecast things with some confidence because of some of the changing demographics and the societal impacts that you see on mental health. However, we are confident about the bolstering of community services. The long-term plan for mental health is built on several years' evidence now, and particularly where we've seen investment in crisis services, particularly in Nottinghamshire, we've seen it ourselves. We do manage to support people at home. And I think when you look at last year, even despite the situations that we've been in with COVID, we have, for the locality, bolstered the local mental health teams with more staff. We now have things like a crisis 24-hour, 7-day-a-week phone line. We now work with Mind to provide stabilisation support, and we have lots of increased capacity around crisis. So I do think the community investment will support the forecast that we've made. And I think even despite the situation at the moment, this coming year sees us working with some key pathways for people, substance misuse, people with complex personalities. I think we will still see that improvement and support people not to need access to inpatient services. I don't mean, however, that people shouldn't be able to access inpatient care when they need it, because that must be there for them. But I do think we'll see a lot of improvement in the community pathways to support people less likely to need hospitalisation. And hospitalisation is not good for all of the people who we might think ought to require it, actually. And actually support in the community can be much more effective for them personally and psychologically. On the issue about keeping a local unit for local people, I can see where that comes from, and particularly about, therefore, the benefits around that of travel. However, professionally, I do feel that people, again, will still need to access psychiatric intensive care. Children will still need to go to a specialist facility, like they do now. That will leave 6 types of patients who will need bespoke environments and bespoke clinical teams. And in such small numbers, those patients will be in very small numbers. It won't constitute a ward or a facility that has a therapeutic milieu or a clinical team wrapped around, for example, 1 or 2 patients. Those patients would be very isolated, and so would those clinical staff. The clinical staff do need to have a volume of patients to maintain their clinical skills. So I would hesitate to support a recommendation like that on a professional basis. I think it would be professionally and clinically isolating to consider a facility like that. The aspect of travel for us as a provider and supporting patients and families is absolutely key. We in the Trust provide national services in one of our sites, particularly at Rampton Hospital. Those families have bespoke care plans around travel, and I think the patients affected by this type of change could have the same kind of care and provision. And we do have carer support services that can work with those families, and we are in discussions with the CCG about what that could look like.
Thank you, Julie. I'm conscious that we've got a very long agenda, so we'll move along quickly. Councillor John Wilmot.
Thank you, Chairman. first of all, I agree with you totally about the service being locally provided. Very difficult for people that are in one area, especially when they've got families to go around with them and make sure that they're able to see them and this, that, and the other situation. As far as the consultation is concerned, I just ask you, is 917 a fair reflection of the total people in Bassetlaw? It's over 100,000, I think, and that seems a very small consultation. Have you been looking at social media in a more proactive way, and the newspapers and all different ways of contacting people to make sure that the right decision in the end is reached? Because of we must make sure that people are aware of the situation and what's going to happen. When you talked about the actual Bassetlaw position, when you started talking about dormitories and mixed gender and different floors and lifts breaking down, etc. It sounded getting a little bit like the workhouse at Southall. That really upset me in lots of ways, to think that we've still got that situation, going on. So obviously, what you first should be looking at is whether these areas can be improved themselves, rather than upheaval and moving everything all over the place. Yes, I've seen Millbrook, I've seen Highbury, and they're both very good facilities. But I'm just saying, the people in your area will not want to go there, but they will probably have to. The third item, of course, is the transport. Yes, it is a real problem, but there are transport initiatives available. We've got lots of taxi firms starting up with brilliant services now, and at very reasonable prices. So I think that can be sorted in that way. I'm just saying. Do you talk with doctors about referrals in Bassetlaw? And you spoke about Rampton Hospital, which I have visited to see the services there, etc. And I have been. People have been in touch with me over situations where people with mental problems leaving prisons. That's another area that needs to be addressed sometimes. Because when a person leaves prison, they're very, very alone, and sometimes their parents or even their grandparents ring me up and say, my grandson's just coming out of prison, he's got real serious problems, mental problems, where can I go to sort this out? These are issues that you've got to be aware of all over the place. And as I say, 15 patients, it's not a great deal on the overall aspect of mental health, and I'm sure that if you do look at the possibility of upgrading the services that you've already got, that might be a good possibility. I've seen mental health in my area. I'm pleased to you do get some people come from Ashfield, because I've seen people walking the streets, because not that they're not asked or told that the service is available to them, but a mental person with mental disabilities seems to very often deny knowledge of anything, and they don't want to know about it, and it's very difficult to get through to them. I've seen it in so many ways. Anyway, that's what I've got to say. Yes, I think change is absolutely essential. With what was said, the dormitories. No, thank you. And I do feel that the first thought should be have a look at the present system. You've got the present accommodation. Can that be changed? and then you start looking at making sure the other areas, Millbrook and Highbury and Sherwood, can take the necessary steps to make sure that the people are looked after well. Thank you, Chairman.
Do you need to answer that, or have you covered it, do you feel, or where are you with it?
I've covered most of it, so I'll try not to repeat myself, Chair. Thank you. So you made a remark about the number of respondents, and was it large enough? Of course, if you add in all of the petitioners, it's over 3,500 as opposed to sort of just short of 1,000. The population of Bassetlaw is 117,000. So actually, it's a pretty good response rate for this type of engagement exercise, and we've worked very hard to do that. And of course, for the number of patients that we're talking about, the numbers that we actually talked in terms of families and patients was about tenfold more than the annual number of people that are admitted. So I think we've tried to sort of get the engagement as broad as possible. In terms of will they go to the new facility, because you mentioned that, well, in one respect, 2/3 to 3/4 of the inpatients currently go in the other direction, so hopefully they will, but it will be much improved services. And you mentioned about taxis and other types of transport arrangements. And there's the Bassetlaw Action Centre that we commission to provide patient transport services. We have another sort of contract with patient transport services, in addition to the options around taxis and so on. So we can wrap around some really good transport support for patients and relatives to be able to visit. I know my governing body has already raised this as an issue of concern as well, and they'll want to see that in detail just as much as anyone. And before any move takes place, if that's the decision that is made, it will be subject to those transport arrangements being sort of finalised and really robust before any change actually takes place.
Thank you. Councillor Jonathan Wheeler.
Thank you, Chairman. I think looking through the report today and listening to the comments made, as sitting here on a scrutiny group, we're obviously here to effectively scrutinise decisions being made, but looking at the information forward, I honestly don't feel like I could make that decision because the information just isn't there. I understand the comments you made about meeting timings, but potentially that should come forward a lot earlier so we can look at where the items should be here today. And I think looking at the papers, I'm not seeing the feasibility studies into keeping the mental health unit in Bassetlaw. I understand some of the figures you just said in response to my colleague, Councillor Bailey, but I'm not seeing that here. Not seeing a full transport plan for residents who need to go visit their relatives in there. So to me, it just feels, and it also feels like decisions have been made. If you're already plastering walls in the new facility, it just feels like you're just here to, as a matter of courtesy, to hear our views, but it's already been made already. So that's why my big concern. I mean, like recommendation 2, to comment on the, I just don't honestly feel like the information is there to be able to effectively scrutinise. That's a real shame because scrutiny plays a really important process. We're here to represent our residents, and Council Bailey's doing a fantastic job for Bassetlaw residents. And as someone who's looking at it from the outside in, so to speak, I'd be very upset if I was a local member and also a local resident just to feel like there's just not been that effective work done in place, because I think if you had all your plans there, what you just talked about, the numbers, that makes sense to me about you saying about £100 million, everything else, but that needs to be there to actually let people know. So this is what the figures are. Would you like us to spend your public money on this, or would you rather we put some more money into effective transport to allow you to get to the new facility there? And that would make sense to me if you were putting that together. But since it's not there, I think you can understand why there's a lot of concern locally. And as I come back to an earlier point, I just don't feel like I can make that effective decision on supporting or even opposing this either way, just because that level of detail isn't there, Chairman. Thank you.
Thank you. Do you have a comment to make on that?
We'll be sharing the full business case, which I think does address, councillors, a lot of the points that you and others have made. And we said right up, and both from the chair and my perspective, that the sequence of this isn't really ideal, and it's not what I would have wanted to see. But was unavoidable from our perspective in terms of the production of that case. I mean, obviously, my governing body will no doubt, I don't want to preempt it, I'm loath to do that, but I've no doubt that it will be seeking some of the same assurances that you're talking about. And I think they'd be interested in your views once you had the opportunity to see the full business case. And I think in terms of, A decision being made versus a decision enacted may be subject to a number of steps in between. And certainly I don't think the new facility or the move, if it does take place, will be very quick. I think Julie will be able to tell me if it's next spring or...
Well, the Sherwood Oaks would not be available to move patients into until May at the earliest. So I do think it's important.
Can you switch your microphone on, please, because we can't hear you.
Sorry, yes, Sherwood Oaks wouldn't be available to move patients until May. And I do think Councillor Wilmot's issue definitely about trying to make the best of what we've got available. The Trust has spent over £300,000 of revenue trying to tackle some of the environmental issues on B1 and B2, but the fabric of the building makes it quite limited. But nevertheless, I can assure you, Councillor Wilmot, we've tried, and I think your points about the wider pathway and patients in the community are absolutely important.
Okay. Yeah.
Just on page 35, it's saying that on point 10, when would any changes take place? If the changes go ahead, we would expect there to be in effect by autumn 2021. Yeah. Sherwood Oaks be raised over to patients from September. That's why I asked that point. It feels like if it's that, well, it's 2 months really, that you would have to have the facility virtually ready to go in that time. I imagine that's why you point out September and May. Can you just clarify the difference in those, please? So
I can clarify that the building will not be available to move patients to until May, and that is a change from previous programmes.
Right, I have Councillor Gowland, and then I have Councillor Guilfoyle, who is joining us by video. So I'll go to him after, he is a local member, and I will go to him after Councillor Gowland. Thank you.
Thank you. On the travel, you said some people will be impacted more than others, and that's clearly true. And we know they'll be the most vulnerable and the most disadvantaged in the community. I found the comments on travelling in the document. It's page 31 of our version. Honestly, I'm sorry to say, but flippant. I'm not going to quote them, but it sort of says, oh, it will make more trouble, make a bit of a problem to some people in the short term, and it will affect some people. It can be a major problem. I'm really lucky. I have a car. I have a flexible job. My mother was put in Millbrook from Rushcliffe. It turned my life upside down. And you know that. You work with people in this situation. This is not a minor inconvenience. This transforms people's lives, and it lives with them for the rest of their lives, those effects at that time. So I think this travel plan, and I can understand there are solutions, but they have to be written down and part of the whole package. But the other thing I'm concerned about, we're about to see the presentation from NUH, the future NUH, and I just wonder what the future holds for mental health services. And I know the suggestion of providing some aspects of mental health care in a sort of hybrid online provision might sound mad, and you might go, well, that's just stupid. But surely these things might be about to change. And I wonder, if you have a specialist services this must be what happens in parts of America and very large countries where they can't have local services very locally provided. There must be some online services. And are we about to, turn services upside down and things about to change? And the reason I'm asking is I'm trying to work out the numbers. Because from Google, I work out that about 14% of the population in Nottinghamshire is in Bassetlaw. As I understand it, 34% of these new beds will be in Mansfield. How many beds are there in Highbury? Because it seems to me that something doesn't quite make sense. The people of Bassetlaw, why aren't they going to their local service? Is it just because they know it's run down? And that's actually the reason. And if it was a brand new spanking hospital, they would be wanting to go to their hospital, not be or is there really a truly reduction in need in Bassetlaw? That seems unlikely. I understand what you're saying about the changes in the way healthcare is provided, but it seems to me that the number of beds is not the right number anyhow in that area for the provision. You must know these numbers. Thank you.
Are you going to come back on that? Could you put your microphone on, please, Judy?
Sorry, we have 70 acute beds at Highbury and we have 30 beds at Millbrook. The provision at Sherwood Oaks will be a boost to the NHS beds of 14. What we do in Nottinghamshire at the moment is we procure beds from the Priory to help people continue to be cared for in Nottinghamshire. Potentially, you know, the amount to which we do that might change for the better. So there is change and there is more capacity needed, and Sherwood Oaks is part of that plan as well. But we do understand where the patients are going from in the city and the county and Bassetlaw. And that's driven by a number of factors. It could be clinical need and it could be choice as well.
Thank you. I'm going to move to Councillor Guilfoyle now, who's joining us by video because he has a limited time that he's available this morning. And then I'm going to Councillor Turner, who is another local member. Councillor Guilfoyle.
Thank you, Chairman. I hope you can hear me.
Very clearly.
Thank you. Thank you. And can I thank you for agreeing for this to come back to committee following my discussion with you. It's really much appreciated. I know it was short notice. Can I also thank Julie, like you did yourself, for the visit that we had the other day, and also for her staff who took us around on the tour. It was, as you say, very illuminating. Chairman, I'd like to start with, you know, the positive bit, which is the fact that we're getting £4 million worth of investment for the community facilities, and you know, we really do need that, and clearly that should be praised. And also, as has been mentioned, the 17 million for the accident emergency, which does impact on this facility, because in reality, the place where they're going to put the emergency facility, as I understand it, is in the building that we're currently talking about now. And although I know that they've not sort of been evicted yet, you know, there's a possibility that that could happen anyway. Chairman, I have significant concerns around the loss of this inpatient facility. Not just because of the travel, and as colleagues have pointed out, how difficult it is currently to get to Mansfield. In particular, there is no Sunday service. And as my colleagues know, I use public transport all the time. And I've got to Mansfield from County Hall, and on occasion not being able to get back other than by a circuitous route, and that was either travelling through to Retford and then back into Worksop, or even in fact having to consider going to Chesterfield to get back into Worksop. So the transport links there are not at all the best, and that really does need some serious thought. And the concern I've got about transport is that I live in a world like we all do, that realistic. One set of individuals and one committee can make a decision about the provision of transport links. But if a new administration comes in and has financial difficulties, they will change that. So there will be no guarantee of sustainability of the transport links unless people are willing to give to such as the Bassetlaw Action Centre a sum of money for a period of something like 10 years that would guarantee that that centre could run transport over that length of time. Chairman, I've listened to the issues about the facility, and I think you would agree with me that that facility does need change, and people cannot continue to live to either work for the staff or for patients to be in that facility. It doesn't meet and wouldn't meet CQC guidelines, and clearly it states in the report that we've got before us that the concerns that the staff have got around that it's not been meeting those good standard guidances since 2013. This has not just come, the concern I've got is this is not just come upon us. It looks like that there have been significant issues in that department for some time. And I understand, as has been said by Julie, that she's £300,000 worth of revenue money has been spent trying to A, keep the lips going, B, dealing with issues around Legionella, C, where they had the roof collapse, etc., etc. And that's not just talking about the mix of patients and the fact that they're still in the old style wards as opposed to having better provision. Now, I look at, and it seems that what the trust are doing currently is throwing all their eggs into one basket, which is locating all the mental health services in the Mansfield area. And that includes taking people from the city to there. And there won't be, where there is a choice at the moment for residents who live in Bassetlaw who say for whatever reason they wish not to be placed in Bassetlaw but go to Mansfield, and where I'm sure there are people in Mansfield who say, well, I don't want to go to Mansfield, can we go to Bassetlaw? That choice will be taken away because it will be one facility, although it be a large facility and a state-of-the-art facility. But I cannot understand why that facility, which it seems though the decision has been made, because clearly, although it's not built yet, it is decided on, and they're not going to build a facility and leave it empty. So in one sense, are we really being consulted, or are we being given a fait accompli? You've got to go here because that's what we've done. For me, if you look at it, that for in particular for the elderly, we discussed with Julie why some form of partnership could not be done in the locality with some other people to actually look at keeping the Bassetlaw people in Bassetlaw for the elderly. And if you look at the size of the facility, why can't that be broken down so that at least part of that facility be built here, which then gives people that opportunity to remain in Bassetlaw, but also people from across the city and the county to be able to have a choice if they don't want to go into their own locality for whatever reason. So I think there are opportunities and which could have been considered. They haven't been considered, and we're really being pushed down this one track of big is beautiful, and I don't particularly think it is. I have to agree with my colleagues who talk about the ageing population that is growing in Bassetlaw and growing across the county, and also that, as we've been saying, that not just because of COVID, but mental illness and well-being right across is becoming a more significant problem and being identified as a more significant problem. I think the beds that are not there, that are there at the moment, that are not being filled, will actually in the ensuing years will or would have been filled from Bassetlaw people. There is no doubt about that. Notwithstanding the improvements to the care that's going to be dealt with in the community, I still think that is going to grow. So, Chairman, all in all, I would ask the Trust to rethink its policy. I think, as I said, it's all the eggs are going into one basket. I think the difficulties that people will have to face in travelling, and it just reminds me of my mum, who is now 90, and reminds me when she had polio when she was 4. She was placed in Bretby, which is some 40 odd miles away from Killermarsh, where she was born. And my grandfather and her my uncle, had to travel only on every other Sunday and bicycle to Bretby to see her. And that was the only visit she got. And she was in that hospital for 3 years. I don't want to see that ever again. And I don't think, in this day and age, we should be making it difficult for people to travel across to get the services that they need. So I should say they should go back and rethink that there is opportunities for working with, dare I say it, the private sector and the voluntary sector to provide that facility, a new facility fit for purpose within Bassetlaw. And that's what the people of Bassetlaw want.
Thank you. Thank you, Councillor Guilfoyle. Would you like to comment on that, Idris?
Again, understanding, thank you, Councillor. And I thought it was a very balanced and understandable sort of statement, so I appreciate that. I think a couple of things I just would pick up on. One is that it's not a fait accompli. The Sherwood Oaks facility was based on a business case that goes back now some time and didn't include Bassetlaw at any stage. So it stacks up in its own right. From a Bassetlaw perspective, it is a clear option that we need to consider in terms of addressing the inadequate, to say the least, inpatient facilities we currently have. So it's more of an opportunity to be considered than a fait accompli. In terms of eggs in one basket in the larger facility, I think Julie's picked up the point a number of times really in terms of the minimum scale that you have for such a specialist facility. And I think it's important that we continue, and certainly as a CCG, we've been very supportive of the district hospital and keeping, sort of as much of the facilities that we have in Bassetlaw and in the district hospital as possible. We're not a CCG that's tried to reduce those services, quite the opposite, which is why we're so delighted about the £17 million worth of investment in that hospital. But the investment in mental health is largely around community and crisis and all the other things we've discussed. And that increases our expenditure over the next 4 years by up to about 20% increase. I mean, there's barely a public service that could say that, I think. So, we're putting our eggs, if you like, in the basket that impacts on most people, that will give the greatest benefit, and actually should reduce the number of people that require inpatient treatment, who are a very small minority that require the highest level of specialist care possible. And it's akin, from a physical health point of view, to an incredibly sick child needing to go to a Sheffield Children's Hospital, for example, where you can only have that level of specialist care when it's provided to a much larger population, much footprint. So that's the comparison that I would give, really. Inpatient mental health is a very specialist facility, and it's a county-wide facility, not just a district one. And unfortunately, it's just not possible to provide the best level of specialist care in a multitude of very small units for the reasons described. And that's a trade-off. And from the public sector perspective, we have to make these decisions all the time, don't we? We have a finite amount of money. So how can we make the best benefit for the most people? And I think that's the question that we're posed here, particularly with regard to the inpatient facility, which is clearly, and I think everybody's agreed, is an inadequate and inappropriate facility that needs to be addressed. And therein lies the challenge and the challenge for us. But the point around transport, I think, has been made very, very consistently, and I accept fully that. And it's a message that I will take back to my governing body in terms of their decision-making process as well.
Thank you. Thank you. Councillor Turner, who is also a local member.
Thank you, Chairman. I echo and support all fellow members' comments. Bassetlaw patients need services locally. I want to be brief, and I want to move on. So, in future, can I ask for more transparency around any future decisions, and particularly more information on the transport plan, as you've just mentioned? And can we explore every opportunity? And briefly, that's all I've got to say. Thank you.
Thank you, Councillor Turner. Well, I think that was just very clear. I don't think I've got Councillor Welsh, and then I haven't got anybody else. So after Councillor Welsh, we'll bring it to a close unless anybody has anything else to say. Do feel that you can interject. Right, Councillor Welsh.
A lot of what I was going to say has actually already been said. I've been eagerly listening, especially to people that are in Bassetlaw, where it's closer to them. There's no denying that mental health is on the rise nationally, and as Councillor Guilfoyle has pointed out, there is an increase in ageing population in Bassetlaw. So there's a few questions really. One of them is, will you be coming back to us in 2 or 3 years' time saying, actually, there's been a huge rise in the area of Basset Law and we need a provision in Basset Law and this is what we're going to provide. And the reason I'm asking that is because with another hat on, I do actually a lot of research into mental health services, and nationally they are preparing for a massive influx in cases, especially in areas with high levels of deprivation, which Basset Law does have some very high levels of deprivation. So that would be my first question. The other question is, you mentioned about £300,000 being invested in the provision, and forgive me if I read off here because my laptop has conveniently run out of battery. If we look at the current state of the provision now, so the MHA ward, 24 beds. The Royal College of Psychiatrists recommends that there should be no bigger than 15 to 18 beds. Both wards are dormitory style accommodation, which breaches national quality guidance. And there's a House of Commons actually paper that recommends that they should be eradicated as soon as possible. The MHSOP ward houses both organic and functional patients on the same ward, which is against good standards guidance, which is a joint commissioning panel for mental health guidance from 2013. Mixed gender, I could go on. So mixed gender wards is not recommended in quality safeguarding guidance by CQC. So a lot of this was born out of the 2013 Mental Health Act. A lot of this guidance with regards. So are we saying since 2013 we've had people in Nottinghamshire having to experience situations like this? So my other understanding is if they want to get outside, they have to use a lift. So if they've got a mobility issue and the lift is broken, they can't get outside. They've got no facilities to do necessarily activities during the day. So my other question is, while it's really important that we look to the future and it's really important that people have state-of-the-art facilities for people with mental health, I have a big concern about the fact that people are having to have substandard services for so long, and there's no denying it because I think the facts talk for itself. And this isn't against anyone that's actually working there and providing those services, because it's a hugely challenging job, and I have no doubt they'll be doing a fantastic job with the facilities that they've got. But 300,000, and correct me if I'm wrong with my maths, if you're saying 300,000 since these recommendations came forward in 2000, so has there been more? There's been quite a bit, have there? Because then there's other things like leaking roofs and things that have caused quite serious health risks as well over the years. So my question is, yes, we're looking to the future and that's great, but I think as a scrutiny committee, we need some reassurances that those people with mental health are actually going to get the services and the support that they actually need, because what's been presented to me to hear as an argument for improving the services actually highlights to me that there's been an issue for a long time that perhaps hasn't been fully addressed. And I'm happy for you to say that I'm completely wrong on that. I'm just reading, as I said, in my other hat as a researcher, and reading into it and saying there's a lot of things that you're not following that are quite basic recommendations with regards to the provision of people with mental health. So that's my other point. So it'd be good to know what improvements have actually been made. And I think the question was raised over there as to when, if it does happen to close down for a reason, when that will be. Are these people going to be in the same provision for that time? So for me personally, there needs to be some immediate changes made with regards to that building, and something needs to be found before then. I'm a firm believer in localised services. I find it, and this isn't against anyone else that's done the research, I find it really hard to comprehend that there is going to be a reduction in people requiring mental health services in the area of Basset Law going forward. And if it is, I suggest you contact the Health Secretary, because you would be completely bucking the national trend and what's going on elsewhere. So they are my comments so far.
Interesting.
I'm sorry if I gave the impression that the £300,000 as a historic measure to it. It doesn't. It's in the last year. The accommodation has been spent money on. It has been modified. Staff do take considerable measures to mitigate some of the limitations that you've referenced. So we don't use all the beds for some of the reasons that you cite. The wards are too big, etc. We have segregated the wards as best we can. So there are mitigations that have been put in place. Notwithstanding that guidance has emerged probably since the 1980s, where acute wards, the policy direction was led by the Royal College and still continues to be. Our trust is a member of the Royal College accreditation service, where its services are assessed against all their standards. So we have got that process in place, but our accommodation does not meet all those statutory requirements. And you're right, those are policies that have emerged over, over quite some considerable time. We're not an outlier in an organisation, and that's why nationally there has been the Eradicating Dormitories capital made available to sort this out for patients in mental health, and we have made use of that, absolutely made use of that capital, and that's why we're hoping and we will be making those some of these changes to eradicate dormitories. That's the basis that funding's been made available. The quality of the care on the ward is subject to a massive amount of oversight and scrutiny, actually, sorry to take your term, but we are aware of the limitations of the environment. So we put in many measures to try and mitigate all of those factors. And, it just isn't satisfactory. I can't come here and say that it is. I think with your point about the population and COVID, we're seeing, yes, an increase in referrals, and at the moment it's not people that are hitting the threshold for inpatient care, so it is going to change. And the investment that's in the transforming community services is based on that targeted needs analysis for Bassett law, actually. The whole configuration of the community service is about Bassett law. If it would be helpful at any time in the future, I'd be very willing to come back on, either specific issues about the inpatient services or broader points about community provision, because we want to highlight some of the changes that we are making. For example, increasing access to cloud technology to support young people. So we are making a lot of those changes to kind of put our services in the best place to manage the challenges.
Thank you. Just go lastly to Councillor Gowland and then we'll bring it to a close.
Yeah, I'll be really quick, and I was supposed to pick up that point again because you made compelling arguments for moving the acute services, centralising the acute services. Three of the alternatives here wouldn't have achieved that, and I think in any future discussions it would be good to explore, or at least have explained to us why alternative distributed models for providing that care are not acceptable. Thank you.
Thank you. Right, members, I think we've all had a very full discussion about this. We've been 2 hours discussing this issue. We're all aware that whether or not the information that we should have is different from what we have, we don't know. We haven't got the full facts, whatever they are, before us to make our decision, whether it is along the same lines or whether it isn't. The issue of transport is central to these proposals. There is no doubt about it. We are here today to determine if the proposed changes are in the interest of the local health service. I'm not sure how we can make that decision. We don't have the full facts before us. We can't even see a survey that was put to the consultation. We haven't got one. There isn't a transport plan for us to look at. We're told there will be one, yet we are making decisions for the people in Nottinghamshire. And therefore, members, I'm going to suggest that we defer our decision today, because I consider this to be a substantial variation of services in the interest of local health service. And I would say to the Bassett Law General Hospital Service that until you can bring us a full transport plan which mitigates the negative impact on carers and staff, we can't make a decision on this. But very unusually for the Health Scrutiny Committee, I shall take a vote on whether you are all supporting this, and if you have any other concerns that you'd like to make a different recommendation, then please say. But if nobody comes forward, I will take a vote to ensure that we are all in favour of deferring our decision until we have many more details before us. And I'm like one or two other people, despite what Indris has said, I feel this decision has been made because your committee meet in a matter of a week, and we are here to make sure that the residents have the best service. And I feel that it's bearing down on us that we make a decision today. That I can't do. I don't have the details before me to make that decision. And therefore, I'd like you to come back. I'd like you to come back with a proper transport plan. And I would like members to have the opportunity to see the survey that went out. And I noticed that you did a telephone survey. Quite frankly, if anybody rings me on the telephone and asks for a survey, I say I haven't got time. And I really do feel that when you cold call like that and people aren't prepared for it, they don't have time to think what their answers are. And I don't feel that's a fair survey, because it wouldn't be if somebody rang me. So I am concerned. I do have great concerns for the people of Bassett Law. I don't feel this is necessarily an improvement to take away from Bassett Law. And as Councillor Welsh has said, with the increase in the rise of mental health, we are taking away a service from a big district. And I don't think that is necessarily the best for everybody. So members, can we take a vote, please, that we determine this, we defer this decision until we have more information before us, and perhaps the officer will suggest that you come back in September, because this appears to me to be moving quite quickly. So we don't want to find that decisions have been made and we've been omitted. We're not here in August. So I would ask, please, that you come back to the September meeting quite early, I think. If I give you the date, I may not be correct, but I think it's the 7th of September, quite early. And we can have some more information and look at this again, please. So can we take a vote on deferral, please? Are you going to second it? Right. OK, let's take a vote. Thank you. Councillor Turner isn't voting because he's not a member of this committee. Thank you very much. Thank you. And thank you to both of you for coming for what has been an interesting morning, despite the fact it's been long. I'm sorry we're not able to make a decision, but that is partly because we haven't got the full information before us. And in order to be fair to our public, we need everything before us. We'll see you in September. Thank you. Members, would you just like to take a very short comfort break? Please don't disappear. We've got more interesting things to come along, and we'll be back in 5 or 6 minutes. Jonathan.
We just pause the broadcast. Thank you.
to afternoon. Um, so I thought you'd all escaped. Right. My apologies for the late delay on our previous item, but can I welcome from NUH Lucy Dadge, who is the Chief Commissioning Officer for Nottingham CCG, Lewis Toria, Head of Insights and Engagements at Nottingham CCG, Andy Marshall, Project Lead, Nottingham University Hospital, and Phil Britt, tomorrow's NUH Programme Director. So here we are. You're coming with some interesting information, and I'm sure the committee will have some very interesting questions. So over to you. Thank you.
Thank you very much, Chair, and thank you very much for inviting us. So my colleagues and I are absolutely delighted to be here with you to bring you up to speed with progress on what we think is a significant, possibly the most significant development for health services in Nottingham for the next generation. And as the Chair said, I've got colleagues from NUH who are going to describe this major programme, and we're going to cover a few key areas. I'm just going to give you a brief overview of the programme. Phil, who sat behind me, is going to give you the case for change. So why do we need to invest in improving our hospitals? Andy Marshall, who is the Deputy Medical Director at the hospitals, will describe the clinical aspiration behind all of this and how we plan to deliver truly world-class care through investment in our hospital infrastructure. Lewis, who is my colleague in commissioning, is going to go through how we have and plan to continue to engage with citizens and elected representatives to shape the proposals. And then with a bit of luck, if we've enough time, I'll talk to you about the next steps and timelines, because this is a significant programme. So just a bit of background from me. And forgive me if you know this, but the Health Infrastructure Plan was launched by the government, I think at Party Conference actually, in autumn 2019, with the intention of ensuring that hospital buildings in England are safe and fit for the future. The programme is exchequer funded, and it will provide capital to invest in both new hospital buildings and also updating the current estate and infrastructure. And it will enable selected chosen hospitals to ensure that their buildings meet the highest standards of privacy and dignity, infection control, which of course is a much bigger issue since this programme was launched, and environmental efficiency, but also to ensure that we can use emerging technologies to treat patients in the most up-to-date ways. So that's the background to the programme. It committed to funding 40 major hospital projects over the next 10 years. So we are lucky to be one of those projects in Nottingham and Nottinghamshire. They're being rolled out in 2 phases. 6 are currently underway. So Leicester, for example, is in the first phase, that reconfiguration of their hospitals. And there are 21 still being planned. And NUH is one of these still being planned. So just to be clear about our roles, the CCG, the clinical commissioners, which I represent, who will become the integrated care system, will integrated care provider, overseer. We will lead a process of engaging with our citizens to ensure that the money that is eventually invested in Nottinghamshire provides the highest possible care in the location for patients that is both safest and most accessible. So that is our role, is to ensure that this proposal delivers the best care and engages our citizens in developing it. We obviously work with clinical and other care experts in NUH, people like Andy, and clinical experts from across the Midlands to determine what we think are the best ways of delivering highest quality care. But clearly, we very much welcome and indeed are required to have the input of our citizens and their elected representatives to help us further shape our thinking. So the plans that we're pulling together, so the manifestation of this will be new hospital buildings, but the underpinning it is a new way of delivering services. The plans that we're bringing together will give due regard to how services are arranged best arranged across the two main hospital sites in Nottingham, so that's the City Hospital and QMC, but also how this works best for patients to access the right facilities, but also how we ensure that we deploy our expert clinicians and support workers in the best way across our hospital sites. And technical colleagues at the hospital will also ensure that the oldest parts of our estate, and some of you will know, no doubt, that the City Hospital goes back to Victorian times, are brought up to modern day standards. So that's our role collectively. And I'm going to hand over to Phil, who I think is going to take you through the case for change. So what's driving this?
Thank you, Lucy, and good afternoon, everybody. So we do think we have a clear case for change for working differently in Nottingham and Nottinghamshire. Our population has changed quite a bit over recent years and will change as we move forward. Like most parts of the country, we've got an ageing population and increasing multi-morbidities, which requires a different way of managing those patients as we go forward. We do have to transform the way we provide care for those patients by working in a more integrated way, which focuses on the prevention and well-being more than it does the treatment of their acute illness. We also know that we need to look at how and where care is provided. Increasingly, more routine care can be provided more accessibly for our citizens and patients, whether that's in their home, in community settings or virtually. And this programme is looking at how we can do that more, which will enable our hospitals to increasingly become more specialist centres, which is the national direction of travel. As well as our population changes, we also have a significant efficiency challenge across the system, which, as our population increases and demand goes up, creates additional pressures on us being able to manage our services. It does require us to work in a more effective and more efficient way. And the only way we will be able to do that is if we transform the way health and social care is provided across the whole system. Next slide, please. So as well as the challenges across the system, there are some clear challenges within our hospitals that we're looking to address through this programme. As Lucy mentioned, much of our hospital estate in Nottingham is very old, and that creates some delivery challenges that we would like to address. In particular, over the last 12 months or so, COVID has taught us that a lot of our hospital estate isn't very flexible to respond to changing demands that our population may have. The provision of side rooms, for example, has limited our ability to manage patients with infections and meet infection prevention and control standards. So this investment and this programme of work will enable us to address some of those long-standing issues that we face. As well as some of the restrictions our buildings place on how we are able to manage patients, we know increasingly when patients come into our hospitals, not only do they have acute hospital needs, they also have many other physical and mental health needs which we have to meet as well. And sometimes our hospitals don't always provide the right environments for us to do that. So again, we want to really look at how we can create more appropriate environments to manage the multiple needs our patients have. We also know that the transformation agenda nationally is creating different demands on our hospitals. As standards change and new guidelines come out, we have to continually respond to some of those things. And actually, the way our hospitals are configured and the lack of space we have often limits our ability to respond to some of those things. So, for example, the recent national review around neonatal intensive care has set a series of new standards that we are required to meet as a hospital, which means we're going to have to look at how we change our neonatal intensive care facilities across our two sites. And the only way we'll be really able to do that is if we are able to invest in our hospital infrastructure to support that different way of working. And finally, we also have a duty to our staff within our hospitals who do a really fantastic and great job in managing our patients on a daily basis. But often we ask them to do that in environments which are very old and very tired. And we know there is a relationship between the environment that people work in and staff satisfaction and their ability. So if we are going to be able to recruit and retain staff as we need to within our hospitals, it's important that we make those investments to upgrade our facilities. And next slide, please. So finally, I think we do have a clear case for change in Nottingham and Nottinghamshire, which will underpin and drive this programme forward. In order for us to ensure that we address that case for change as we develop our proposals, we have identified a set of objectives which we will use to check back against to ensure that the changes we make and the investments we want to do will help us address some of those issues I've just described. I won't go through them all on the slide, as you'll be able to see them all there, and you'll see the direct correlation between some of those things and the examples I have just given. I'm now going to hand over to Andy, who'll talk a bit more about the clinical proposals.
Thanks, Phil. Good afternoon, everyone. So next slide, please. That's perfect, thank you. So I'm just going to give you a flavour of how we've gone about engaging with internal and external stakeholders to form a clinical advisory group to start our initial thinking around our clinical model and how we are going to deliver care in a forward-thinking fashion for our population. You've heard Lucy and Phil both refer to the words aspirational and transformational. I think we all recognise this is a once-in-a-lifetime opportunity really to transform how we deliver care for our population in Nottingham. And so we've gone through a number of stakeholder events. You can see on the slide the details of the number of people that have been involved. And I'd like to highlight a couple of key points really with our Senate review. So there exists an East Midland Clinical Senate who stretches throughout the East Midlands and is a go-to body really to sense check and have adequate clinical and other challenge for our plans. And we went first in December 2020 for a review of the entire programme. And following further refinement and challenge, we've had a further Senate review most recently in April, focusing really on maternity care, cancer care and emergency services. And I'd like to share with you on the next slide what our sort of aspirational our clinical goals are. You've heard Phil and you've heard Lucy say, how do we make best use of our provision across our system? And really that it is a system-wide approach about how we deal with healthcare. We're not just being a reactive service as an acute provider. We need to think very much on the prevention agenda, as people have said, and how we transform the health outcomes for our population in Nottingham and Nottinghamshire. So really, we want to focus on where care is delivered and focus on what can be delivered safely and well outside of hospital and what we do need to deliver in the hospital. So very much we're focused on how we deliver care for our population across the whole piece. At the moment, we have different portals of entry to our two hospital sites where we treat for acute inpatients. And really our second overriding principle is wherever possible, accepting there may have to be some exceptions, we're going to attempt to focus all emergency secondary care on one site. What we want to avoid is having to move patients around the ring road as we've had to at times of acute pressure. So that both the patients get the safest experience they can and the best patient experience. So that's really a driving principle that we're aiming towards. Our third principle, and you've heard some reference to it from Phil there about how we consolidate women's and children's services onto the acute site, so that both our paediatric population, in particular our neonatal population, and our women and families get the best care located on one site for our patients with access to all the ancillary services that we need to support women and families who become acutely unwell. Principle 4, I think you'll have seen all the interest in the national press, and you'll be aware of the extensive pressure on waiting lists that we see to be climbing nationally. And so in order to try and protect our elective programme as much as possible, we want to try and separate out elective care from emergency care, a so-called hot and cold slight split. This means that at the times of our most intensive pressure for emergencies, such as wintertime traditionally, that we will be able to maintain our elective workload for those patients who've been waiting for a significant period for their elective surgery. So we really want to drive towards that model, which again is a national directive. Cancer care is a huge part of the services we provide, and where we cite cancer, it's important that we have all the ancillary services that need to support those patients who have a myriad of medical needs and support service needs. So we need to ensure that there's a critical infrastructure, critical care, and those acute medical services that can look after those patients who are at their sickest and lowest ebb, and we need to ensure that we can look after them. And then finally, we're in an age of technology and enablement, so we need to think again about where we deliver care, where we deliver diagnostic services, where we deliver outpatient services, and how we use electronic and IT infrastructure so that we can maximise the patient experience but minimise the disruption that they have. Traditionally, secondary care models has been that the patients come to us, but very much throughout the pandemic, it's enabled us to look at about how we might deliver care differently, and a lot of consultations in patients' own homes, prevent them from having to travel, particularly with young families, engage in parking and all the stress that goes with that. And so we're really looking as to where we add value, how we add value, and how we use technology to enable that. So thanks for that, and I'm going to hand over to Lewis.
Thank you. Lucy, Phil and Andy have all talked about the scale and ambition of the programme. So we've just started this bit of the presentation with a reminder of our statutory duty to involve members of the public in service change. So you all know that, but we just want to be really clear and signal that we recognise this as a major service change. We recognise that we need to consult the public, and the scale and quality of our consultation will reflect the scale and quality of the programme. Next slide, please, Martin. So in terms of assurance around how we'll go about this, as with all public bodies, we will hold ourselves to the guiding principles for consultation, which you'll be aware of. So we'll consult when proposals are at a formative stage. So some of the papers you received today are from the early engagement we've done, which is far in advance of any formal consultation. Number two, that we give enough information to enable people to make an intelligent response to the consultation. Number three, we allow enough time for the consultation, and importantly, enough time for us to consider the responses to the consultation. And finally, that we can evidence that we've taken the result of the consultation into account in any decision that we make. Next slide, please. So in terms of the structure of the conversation with the public, this is more of an ongoing dialogue than a single consultation exercise. So this is a conversation that we'll be having over a period of over 12 months. So we started in November, December last year with some early engagement at that stage, fairly high level, talking about the clinical model, some of the key principles, and the reports you have as appendices for this meeting are from those exercises. We've got another round of public engagement planned where we'll talk in a little bit more detail about the proposals, and then finally a public consultation where we will set out in detail the changes that we want to make. So we just want to be really clear, this isn't a single consultation exercise, it's a dialogue. We've started fairly high level. As the programme progresses and we get detail within the proposals, we provide more detail to the public. So it's an ongoing conversation. Next slide, please. Backward look, so you'll have the two reports that we have from the early engagement that we've done. So we had some work from agency and some work from Health Watch. Broadly, most people are supportive of the proposals. Just bear in mind that at the stage we were at in talking to people, it was a fairly high level. We were talking about the clinical model and key principles and not detail. People were concerned about access and accessibility, as they often are in this kind of programme. Want to know how services are going to work together. So how do acute hospital services, community care services and primary care services link together? People asking about the affordability of the programme. At the time, there was nothing in the public domain about funding available. And on the kind of key changes that we were outlining, so centralisation of emergency care and maternity care, people are broadly supportive, see the value, but as you'd expect, concerned about access, accessibility, travel and choice. So we'll need to reflect those things as we move forward in the conversation. Next slide, please. So looking forward, as I've said, we've got another round of public engagement planned before we get to a consultation. It would be a fair jump to go from a high level conversation about key principles to a detailed proposal. So we want to talk a little bit more with the public. When we do get to the consultation, it's always difficult to lay out in detail what that will look like before we have the proposals and before we have a consultation document. But I'm just going to spend a minute talking about some of the principles and some of the key things that you'll see when we get to a consultation. So we're planning for 12 weeks, 12-week consultation starting, we plan for February next year. We'll be committing the right amount of resource. It's the largest programme a lot of us will work on, and the size of the consultation will reflect that. We'll also make sure we allow a significant amount of time to consider the responses. So we're expecting a lot of interest, and it's just as important to have time to consider those responses as it is to talk to people and get the responses in. We will subcontract to a research agency for the analysis and the reporting, so there's some independence there. And throughout the exercise, two of the key things that we will always focus on are accessibility, so everything to be as accessible as possible, and targeting as well, so reaching out to as many communities as we can. We'll work with the voluntary sector, we'll work with Health Watch, we'll work with consultation experts. We'll particularly try and target the populations that we've most impacted, so those using hospital services now and in the future, and those populations whose travel time and other service use is impacted. Next slide, please. So just a quick run through some of the activity that you'll see when we get to the consultation. So in terms of documents, as you'll be aware, we'll always do a consultation document. A programme of this size will need a lot of other sub-documents running off that. So if people are interested in maternity or outpatients or anything else, they can read in detail about that. What will be different about this consultation compared to previous exercises is we will proactively translate all of our written materials into the most commonly spoken languages. So usually in a consultation, we will do that reactively. So if someone asks for something in another language, we will translate it. Something of this scale, we need to make sure as many people as possible can access the information. Next slide, please. We'll have a bespoke website set up for the consultation, lots of video, animation, case studies, interviews with staff and patients. So essentially providing information in as many formats as possible so as many people can connect with the information. Again, the core video content will be translated and we'll have BSL versions as well. Next slide, please, Martin. Promotional activity. So we want to have more responses than we've had for any consultation in the 6 years I've been working here. So in addition to the usual things we do, we'll put some resource into paid for social media advertising, so Facebook advertising, which we had a lot of success with in recent exercises. Next slide, please. And then finally, the kind of core activity of the consultation. So these are the things you'll see us putting out there to try and get people to respond. So this is about providing as many opportunities as possible for people to give their views. So we'll have a core questionnaire. We'll outsource the questionnaire to a research agency. The reason being, when you're in the thick of a programme like this, it's quite difficult to write questions that are objective and kind of separate to the business. So we'll have somebody else draft the questions. Core events programme, focus groups for a drill down into the specific areas. Quite a large programme of community engagement, and then some work with voluntary sector and Health Watch as well, which will be contracted work. We've started offering events in other languages, so we've got a lot of clinicians who speak more than one language. We have interpreters, so we're able to offer a wider range of foreign language events, and we'll be out and about in communities as well. So we'll be doing work out in the community and in the hospital as well. So I'm going to hand over to Lucy to wrap up and talk about what happens after the consultation. I just wanted to close this bit by saying this is, in the 6 years I've been doing this work, the biggest exercise we've done of this nature. We're taking it very seriously, and as I keep saying, that the scale and the quality will reflect the size of the programme, and it's very much an ongoing dialogue. So you will see us talking to the public over the next 6 to 9 months before we consult.
Thank you, Lewis, and hopefully I can wrap up. So we keep saying, don't we, this is once in a generation, and it is. And there is, clearly we have got to discharge our obligations to our local population, which are in statute, but also we have some obligations that we have to discharge through to the national NHS England and improvement regulators. So just briefly on the programme then, as Lewis has described, we're going to carry on talking to the public until autumn. And at that point, we start to synthesise all of the clinical thinking that Andy and his colleagues have been doing and continue to do. And we work with the East Midlands Senate, we work with the West Midlands Senate. We will take clinical insights wherever we can to make sure that we get this right. We need to synthesise all of that clinical thinking. And I would just reiterate that in certain areas, some of this clinical thinking is about technologies and therapies that have, are very emerging. And we want to make sure that in things like cancer, that we can really build a hospital that is fit for the future. So we will synthesise all of that with the public feedback, because we need to go to the public with our clinical thinking clear, but really be sure that the public can then input into helping us shape this into a full proposal. So when we've got that clinical thinking and the public insights, The CCG, as we are now, has to consolidate all of that into something called a pre-consultation document, business case. And I will tell you these terms because you will become familiar with them, the PCBC. So that is the document that we have to write that says we believe that we are ready to go out to public consultation. That will be typically, I should expect it'll be a document somewhere between 600, 600 and 1,000 words. So it'll be a big document, and as in parallel. So that's the document that goes for regulatory approval, but is also available to the public should they want to dip into the detail. So in parallel with developing the pre-consultation business case, which is the consolidation of all of the thinking together, we'll write the consultation document. And once everybody's satisfied locally, so yourselves in your statutory role, regionally and nationally, because we have to get national approval to launch public consultation of this scale. Once everybody's satisfied that the pre-consultation business case is robust and reflective of the best clinical thinking and informed by and sensitive to local population factors, we do two things. We get NHS England approval of the pre-consultation business case, and we then simultaneously share that with yourselves together with the consultation plan and the consultation documents. Now, you clearly have a role in considering whether you feel that we are ready to go to public consultation, and we will be very respectful of that role. It is possible that that other health scrutiny committees may be giving similar thoughts, given that NUH provides services to a broader geography. So that is the point in time at which we are able then to say we're ready to go to public consultation. So there will be a huge amount of scrutiny to get us there, including yourselves, quite fundamentally. And we would think that we'll be coming to you in late winter, early spring to say we believe we are ready, and then we would run the consultation, the actual public consultation for 3 months in late spring next year, as the programme shows. And then, as Lewis has described, we gather all of the intelligence from the consultation, independently evaluated to avoid things like confirmation bias. And we then have to put that into what's known as a decision-making business case, DMBC, which again is a phrase a term that you may well become familiar with. And it's the decision-making business case that says we had these clinical ideas, we sought these public insights, we've brought them together, we've evaluated, we've assessed, and we think this is the model that we should be proceeding with, informed by public consultation. And that is quite a milestone moment for us. We will be an ICS at the time, and that decision to proceed on the basis of what is written in the decision-making business case has to be taken in public, and clearly we would have updated you at that point before we made a public declaration of the proposal that we support, and we then hand that over to the hospital, who then do the work that they have to do on the detailed business case around what the buildings are like, all the financial aspects of that. And hopefully we will be in a position to hand that over to the hospital in the summer next year, following a successful public consultation. The hospital do their detailed work on the business case, and as the programme says, construction will start, we hope, early 2025, and we hope finish mid-2029. So thank you very much.
Well, thank you to all of you. That makes me feel tired to even listen to it all, quite frankly. So you're hoping to have this up and running, literally, by 2029?
Yeah.
How much money, can I ask, is this going to cost?
Well, I suppose I would have to answer the question by saying we don't know, because it depends on, there is a ceiling, there is a certain amount of money that the government have set aside, but our job is to, so we do have a ceiling figure, but our job is to develop the best facilities and then to look at the cost effectively. But we don't have a bottomless pit of money. We have a ceiling amount that we are able to invest in capital terms.
And before I hand over to the committee for their questions, which I'm sure will be interesting, with all the elective surgery that as building up and building up. And if we have a crisis in the next few months, we'll build up even more. Presumably this money is totally ring fenced, but is it going to delay the elective surgery? Because that is what people are worried about, all the operations. Could this money, you're going to say no, be put into it, but how can we speed up those operations while all this is going on?
So I can answer your direct question. So the money that's set aside for the hospital buildings is set aside at Treasury. The total pot for the 40 hospitals is ring fenced, as far as we are aware.
And it's
capital can only be spent on buildings. So I don't think, I can't comment, but I've no reason to believe that would be eroded by the issues that we are now facing with a potential third surge of COVID and catching up. I think as we have made public in Nottinghamshire, we are lucky that our two hospitals, Queen's, NUH and Sherwood Forest, have agreed to work to accelerate our elective recovery. So we have had additional money from the government to help us do that. We are managing to keep to those accelerated trajectories. So we are treating more patients than other people. We are catching up more quickly. So I think the two are separate. So we have a separate pot of money for elective recovery, which we are using, and we are seeing the numbers coming through. I see those come through on a weekly basis. Andy sees what it's like in the real world. So I think the two are completely separate. So we're all the same people having to put the effort into pushing the new hospital forward versus managing today. And managing today is managing the increasing number of elective emergency admissions, as well as trying to do more elective care. But I think we've just got to keep trying to do the two in parallel.
Okay.
I think what I would say about the elective recovery, I know we're not here to talk about it, but we have got a genuinely really good track record. We've done really well. I think I've said this in previous meetings, really well in Nottinghamshire throughout all stages of COVID, getting our cancer patients treated. We have been selected to be one of these 11 accelerator sites nationally. The hospitals are pulling out the stops to see people. You can never say where we're going to go with a third COVID surge, but we're doing our best.
Thank you. Members, it's open to you now to ask questions. Who's going to go first? Councillor Wilmot.
Interesting, very, very interesting indeed. Obviously, I'm involved with a number of surgeries, just as a layperson, and I get to know a lot of issues about services. And the majority of people now are, although they're very happy with the two major hospitals and the superb service they get there, many of the people are talking about having it's far better to have a super surgery with small operations in 2 or 3 places in the districts rather than be carted off to the hospital, because there are so many issues going into hospitals. Parking situation, the cost of the parking situation, getting through the traffic, the amount of traffic. You can go from Hucknall to the major hospitals in Nottingham, and it can take you up to an hour and a half sometimes. Sometimes it's only 30 minutes, etc. But it is a real problem. As far as consultations concerned, I do feel like I remember when the CCG was formed. I was on that committee at that time, even talking about it. And at that time, the suggestion was that every district had a meeting, a really good meeting with all the community groups, charities, and everybody involved. That's in each area, one meeting, which could involve 300 people. And in fact, the meeting I represented, there were 70 proposals put forward, and it helped that issue tremendously, because you got to know exactly from so many different people there with different views, and had been involved with the hospitals, been involved with surgeries and so forth. It was appropriate, really appropriate, that you get in touch with the community to make sure that they know what the situation is. Caval services, yeah. I mean, in Appendix 1 of the report, on paragraph 3.2, it states how healthcare needs are changing. This is especially true in places like Hucknall, of course, which you know is on the pipeline at the moment with discussions. Obviously, I don't want to put you under any pressure at all, but obviously there are other areas that kind of service it would be appropriate. Because, say, 3 or 4 areas which would help the hospital to control the overflows that occur, you know, and people are more and more onto that situation. And I just wanted to ask you, I know it is the information that's coming out from the Hucknall discussions, is it progressing, you know, for a possible Caval in Hucknall? That will be, you know, the people have been asking me so many times, and it just seems to me at the moment everybody's not saying anything. You know, the amount of discussions that I know they're there, but nobody's telling me anything, and I'm the councillor. I think I ought to know something about it, you know, on that issue. As I say, I'm surprised no one's here from Health Watch.
I can tell you that the lady who normally comes is ill.
Oh, right, because it's such a big load of paperwork from Health Watch, and they seem to have done a rather good job, actually. Because at times, I remember when Health Watch first started, I was in discussions with them, saying to them, what is your job? You know, I'd like to know. But however, it's great news that Health Watch seem to be doing a good job and putting you under pressure, which that's what it's all about, whether we like it or not. It's only under pressure when you get the better services that's going. So, as I say, thank you for all the work that's being done, but there is a lot of pressure at the moment on local services, and I hope you take that into the discussions. And please do as I ask, make sure that all areas are represented on this consultation and get the opportunity to talk. Thank you.
Thank you. Okay, Lucy, do you need to answer that? Or
just on the Caval Centre, I can't give you any detail. I could have done if I'd have known you were going to ask, but that's by the by. But I can give you an absolute assurance that the Caval Centre is the kind of facility that we are absolutely committed to developing. That it will enable us to bring a whole range of local services together beyond healthcare, so that people can receive support and help away from you know, traditional settings. And there may be, you know, that sort of setting is unlikely to do any operations, but it may well have outpatients, clinics. So that's absolutely the sort of thing we're committed to. We are working on it. I do know that. My team are working on it, and we're bringing together kind of a governance structure to make sure that everybody's represented. I believe, you know, we're going through the process of business cases, and I believe that will come to fruition.
Thank you very much.
right, members, who's got a question, please? Councillor Welsh. Oh, can I ask Councillor Wheeler first, because he can't stay very long?
Thank you very much, Chairman. I think you know, it's great to see the level of detail you want to go into your consultation. You know, we've had a presentation today where the consultation was woeful, I think is for a better word. So it actually is really good that you're doing that. And I think what's also important to say is we've got our big hospitals, obviously really crucial. Also the small hospitals, for example, Lings Bar in my patch, you know, which is very facility, and Tina do a good job. So it's really important that we can focus on all these centres to make sure that we're getting the best out of them and they're doing what they need to do. But I just ask the consultation really is, you know, if you can deliver what's put in that presentation, it'd be absolutely fantastic to make sure you get wider response. I think especially going for younger people more on the social media side will actually give you a better representation, hopefully, than what you've had before. So it's really good to see that, and hopefully you can teach some of your colleagues in Norfolk County how to do it. Thank you.
Thank you, Councillor Wheeler. Councillor Welsh.
Yes, very, very quickly. Just some clarification, really. I remain quite concerned about the remote care processes, and that is probably largely to do with a group that I'm involved with that have been involved in kind of remote because of COVID. So they've had the consultant. They don't feel, and this is a feeling rather than actually what is happening, I think, which is why I'm saying I'm a bit some of it perhaps is a lack of knowledge and perhaps a lack of understanding on people's part. But I think the remote care process can be quite difficult for people. So really it's a bit of it's a question with regards to, would people's care processes be part of a hybrid kind of solution where some would be face-to-face and some wouldn't be face-to-face? And if, for example, a patient would say, actually, I feel much more better and be able to articulate how I feel if I'm on a more face-to-face appointment, whether that would be something that would be, you know, agreed with. So that's the first thing. The other thing is, I'm really firm believer in the localised provision, especially with things with regards to the early identification of diseases such as cancer, which I think helps absolutely everyone, helps you and it helps obviously the person suffering. When we're talking about that, are we talking at GP surgeries? Would they be taking on that? So that's my other question. And sorry, last question, but it's all in with the same thing. GP surgeries, quite a few friends that are GPs that tell me that they are quite over, that they've got so many people wanting appointments at the moment and they can't see really an end to that. So what is it with regards to GP surgeries that you think that capacity is going to improve? Are you suggesting that a few years down the line, if we're talking about 2029 or if it is, the capacity will have increased? And my last thing, and I wouldn't be me without making this point, unfortunately, I notice on the second page of the yellow paper, which in ours is page 45 of 170, it mentions about maternity services going into one place. I'm assuming that you're saying that there wouldn't be maternity services at the city and at the Q. Is that what you're saying? What exactly? Because it says we want to provide all care for children all in the same location, all hospital maternity services in the same location. So I just would like some clarity on that, especially because it was only a few weeks ago that we had maternity services here, and I don't believe this was ever mentioned in their plan that they brought to us. So it'd be quite interesting for us to know what that exactly means for maternity services, because I would say at this moment in time, I think that's the least of maternity services worries and concerns. So.
Thank you. Would you like to reply?
Yes, I'll lead off. I think I'm going to ask Andy to help with some of the more clinical issues. So on the remote consultations, I am just going to say, and I think possibly as a practicing clinician, you can give a more sort of real response to this, but we are very aware as CCG that we can say, you know, there's been a huge increase in remote consultations through COVID. What a great thing that is. Well, it is a great thing for some people who are digitally literate and all that sort of thing and have got the time to work their way through all the remote technology. But we're also very aware that it risks exacerbating health inequalities. So it's great for the people that can access it. It's not for those that can't. So from a commissioning perspective, we recognise that. I mean, Lewis, you did some really comprehensive piece of work, didn't you, in phase 1 COVID that basically told us that. And so from working together, because we don't want to be commissioners and providers working separately now, I think we do recognise that and we will provide that blended model as much as we can. What we don't want to be doing is dragging people into hospital, 3 buses in a tram, you know, for an outpatient consultation that could easily and better be done remotely, both for them. But I think that blended model is absolutely where we will end up. But I think we have seen some benefits of people accessing remote. I don't know whether either Lewis.
Sorry, if I may, I've benefited.
Yeah,
personally.
but if if English isn't your first language, if you don't have access to technology, if you're a care leaver, a young care leaver who is living peripatetically, it's not very easy, is it? So we've got to recognise that people have different, and we mustn't exacerbate health inequalities by saying it works for everyone. I don't know whether anything you want to add, either of you.
Yeah, I mean, in terms of the work we've done on remote consultations, what we found was, I think people usually assume it's Skype and FaceTime. It's predominantly telephone. So most remote consultations are on the phone. There was an assumption when we started that work that the driver for whether people liked remote consultations or not was their age, and it's mostly not. It's what the consultation is about. So people are comfortable talking about some things on the phone, other things less comfortable. So it depends what the issue is. In terms of health inequalities, even though most remote consultations are phone, what we found is there are people in our community who don't have access to a phone, or they have a shared phone, or they don't have credit on their phone, or they don't have a private space. So we do recognise that it's massively beneficial for some people, but for other people, they just can't access the phone to do it, or they're not comfortable doing it.
Thank you.
Yeah, I can give you a bit of personal experience there. So I think you hit the nail on the head there with the phrase hybrid. So at the start of the pandemic, we were not seeing anyone apart from absolute urgent cases, and therefore we defaulted to reaching out to our patients via telephone because that was an easy medium. I think subsequently what we've done is now we've got the ability to see patients again face to face. We're finding out where that model sits best for our patients and our specific services. So particularly for new patients, often seeing patients face to face where you need to perform a physical examination is paramount. But for more follow-up purposes, and that can be quite a really good medium that saves the issues that Councillor Wilmot's raised about parking and the transport issues. And certainly, as Lucy and others and yourself have highlighted, that equity of access is key. So clearly, my parents are in their 80s. Their access to technology is very different from my 17-year-old daughter. So it's finding what sits right across the patch for all our population. So very much, I think we're still sort of finding that happy medium that's going to be best for our patients and our clinical services. So I think you hit the nail on the head.
Thank you. Councillor Henry.
Yes, thank you, Chair. I've noticed that this piece of work is quite exceptionally large, and I've noticed that there is an exercise that you do with the CCG using J. Harvey research. What I'd like to know is how were they chosen, and where can we view a record of previous research engagement in this area? It'd be useful to see that.
Okay, we'll hand over to Lewis. I'm presuming they were chosen through a brief being written and a procurement exercise, but Lewis, you ran that, didn't you?
Yeah. Could I just let me finish it first, and then please. And can we sort of see a copy of the questionnaire, and we'll be able to find out exactly how it was developed? Is there any way we can do that, or which items in the questionnaire were designed to address the health inequalities? I know you mentioned some health inequalities earlier on. I noticed in one of the paragraphs, I think paragraph 2 of that report, there were some issues around health inequality, and how was that done? And I noticed that numbers overall aren't really impressive, really. The CCG engagement exercise resulted in, I think, extremely similar sample, and it lacked diversity in ethnicity and any alternatives, really. So, for example, the cancer care focus group has a sample of only 4. So that sort of thing we just want to clarify. Thank you.
Yeah, so in terms of that round of engagement, there's 2 organisations that we contracted with. One is Healthwatch, who we've worked on with consultations in the past. So what Healthwatch can help us do is reach out to some of the communities that we struggle to connect with and don't have contacts with. So that's why we use Healthwatch. Second organisation we work with is our organisation called North of England Commissioning Support Unit. So they're a semi-commercial organisation, but they are part of the NHS. So they are consultation experts. So the reason we like to work with commissioning support units or CSUs is they have the expertise in consultation, but they are part of the NHS, so they were contracted to do that work. The report is from an agency, so they have subcontracted the report because they've delivered the exercise to make sure that we have the maximum objectivity in the report. It's subcontracted to another agency. That's done through the CSU. In terms of numbers, yeah, they're nowhere near what we'd expect in the consultation. I think it's probably worth highlighting a bit of a difference in objective between the engagement and the consultation. So the engagement is all about conversation, dialogue, insight and feedback. By the time we get to a consultation, it's about making sure as many people as possible can respond to that. I don't normally commit to a number of people we'd be aiming for, but for an exercise this size, we would be looking for in the thousands and a much broader demographic. So you're right to flag that it's not an even demographic or not an appropriate demographic in that early engagement. What it does mean is that we'll put more resource into the voluntary and community sector who can really help reach in some of the communities that we do struggle to get to. But I'm confident in the consultation that you will see far higher numbers of people responding.
All right.
Can I just ask more?
Yeah.
The bit that we're concerned about, and I know a lot to talk in the reports around cancer care, and that, as I said, that sample is very small. And are you going to go back to that again and look at that sample within this cancer care group?
So the next round of engagement will do two things. So one will be another series of public events. The second thing we'll do, which will give us better insight, will be to go and do some targeted engagement. So to reach out to cancer groups, to different users of different hospital services, to start to have some quite specific conversations. So maternity groups talk about maternity services, cancer groups talk about cancer services, other specific communities, and as well the two geographies around the two hospital sites where those populations are quite impacted. So more targeted activity in the next round of engagement, and definitely in the consultation as well.
Thank you. Councillor Gallen.
Thank you. I think when this amazing piece of work, obviously there's an awful lot of stuff here, and I think when we first saw it, it wasn't obvious that this is one of many consultations, and it would be kind of good to have the whole overview, because now it makes much more sense in context, because the numbers seem so small for such a large piece of work. It'd be good to, well, you have sort of reassured us, but to make certain that the next consultations do reach out to the most hard to reach communities, because it's clear, as we've said, that it's not necessarily happened at this stage, but now this sort of makes sense. And the only other thing I'd like to say, we've spoken a lot this morning about localisation of services, which I think everybody agrees is good for people. If you can reach your services, you know, around the corner, that's much better than travelling to a big hospital. But obviously, you sometimes have to go to a big hospital. We've talked about online services and hybrid models, but I'm presuming you're sort of considering hybrid models where the online services are available in the GP, because that is the other way around, isn't it? And I haven't heard anybody mention that, but presume that's on your radar. Thank you.
All right. Councillor Adams.
Thank you, Chairman. Yes, thank you for the presentation. It was very informative. A couple of things. Just I want to touch on what Councillor Welsh said around the care being in one location. Something that was, I think, the Circle unit that was at the QMC, which I know now is back into the hands of the NHS, and previously was, and probably acted as some sort of marker maybe for the future of how care operated, having been someone that used it to have all those services on one site, meaning that you go in to deal with rheumatology, but then you've got x-rays down the corridor, you've got all those accessible services in that one point. Must help with a lot of things around infection control and that sort of thing, because you're not sending people around a ginormous route to get to where they need to be. And I'm taking from what you said around care being centralised into all in one place. Is that what you mean in that sense, that you'll be able to get those services accessible? If you need a chest x-ray because they need to check your lungs, you can have that chest x-ray within sort of 30 minutes, rather than those extended periods of times, new appointment, off you go home again, back you come in again. Because I think it worked incredibly well. It felt very professional and operated in a very slick manner. Further to that, just the business case. I can't remember your acronyms. There was there was a few of them, but just to say on that, I assume some sort of bite-size, accessible. I recognise. I think you meant 10,000 pages rather than 10,000 words. Yes. So just a sort of accessible version of that would be obviously useful for the people, specifically residents, that are going to have access to that document, because anybody greeted with 10,000 pages is not going to pay much interest in the nicest possible way. And secondly, yeah, I mean, thirdly, I should say, glad to hear that the work's going to be starting in 2025. I mean, I think sometimes these things seem way too far in the distance, but that's positive that that's close. So yeah, that's it from me. Thank you very much.
Do you need to comment, Lucy?
Yes, I can respond. So yeah, no, absolutely. Interestingly, the pre-consultation business case, which will be the big document, probably 1,000 pages, will probably be embedded in the consultation documents. The consultation document is the one that will describe the purpose of the consultation. People can then access this bigger document if they want to, and then there will be an easy read version as well. So we will get colleagues who are expert in communications will ensure that however we need to get this information out to the public, we do. I think you comment about one-stop shop and bringing all the diagnostics for people that need to come into hospital and have all of their diagnostics and be worked up as much as they can in one place. Absolutely. We hope that we feel that the treatment centre runs exactly the same way as it ever did. Probably the only other thing I was going to add to Colin, we've talked a lot about localisation of services. I think the other thing, particularly when we think about cancer and we've talked about neonatal, is to remember that in the Nottingham hospitals in particular, we are fortunate for our population to have regional specialist services. So you are talking what are called tertiary, they're most specialist services that can be provided in hospital. And we need to make sure they are provided to a bigger population, but clearly for our population, it's great that they can access them on their doorstep. So this is a lot about as well securing those really highly specialist hospital services for people in Nottingham.
Has anybody else got any questions to ask? Councillor Wilmot.
Sorry to come back, Chair, but I've just forgotten something. You talked about that we're all looking for the future of healthcare in the NH and NUH. Surely we need also to look at the future of all healthcare, which doesn't mean the health itself, but the preparation, the situation where prevention services are very, very, very important. And it does seem to me that it's not an issue that we get enough information on, and the patients at surgeries and so forth don't get enough information on. Exercise, absolutely essential. Obesity, and all those sort of things that unfortunately, if we get a hold of that issue, it would save thousands of hours of hospital work and lives as well. That's the most important thing. And I'm just saying, to what extent in tomorrow's NUH is it just about transferring services into the community? If this is the case, I'm afraid I have to bring Hucknall up again on this situation. Does that mean we will finally tackle the Hucknall's health crisis? The report states that the restructure of the NUH could take up to 20 years. You put that into the situation. Is that time frame accurate? And what work has been done to assess future healthcare needs to ensure it is fit for purpose? I wonder if you could give me a little bit of info on that. Thank you very much, Chair.
Welcome. Lucy.
So we will do this as quickly as we possibly can. And as we said at the moment, based on the national process that we're in, the work, because we want to get it right. It's a balance between getting it right and doing it quickly. But we believe we can have the new hospital open by 2030. But I think as we've talked about a lot today, that means a lot of other things changing around it. Councillor Welsh mentioned general practice. We need to sustain and secure general practice. So if we are going to be asking general practice to do a lot more to support prevention, when people are. So one of the things that we're doing at the moment to support our elective recovery is what we're calling list preparation. So if you're on a waiting list for your hip replacement, we are, secondary care doctors and your GP are talking to you about things like smoking cessation, weight management, exercise, what you can do to get yourself as fit as you can, so that when you get your hip done, you might only have one hip done, as opposed to potentially ending up having two. So I think this will all come together. The hospital is the bit in the middle, but everything else has got to work around it. And Councillor Welsh is absolutely right in highlighting that we've got to support general practice, got to support individual GPs, we've got to put, and we are putting, that the government is helping us put additional resources into community with more mental health workers, more physiotherapists, all those things in the community that will support people, hopefully not to have to go to hospital.
Thank you. Yes.
Thank you, Chairman. Yes, just wants to add to that point. I did forget to mention, because it was something that Councillor Wilmot mentioned around the parking element. And I think another fantastic thing about the treatment centre is its parking is all underneath. So if you're going there, you can park exactly where you need to be, get in your car, get out, do what you need to do, get in your car and go home. And I think that's, again, an accessibility thing which works incredibly well. It makes people feel like it really is something they can get into quite simply, and it takes away a bit of that anxiety that I think some people feel about entering the hospital environment. So just wants to add. Thank you.
So, members, any more questions? No. this isn't the end of the line, is it, with NUH? Lucy, can I thank you for coming in today and also apologise for our delayed start. I think I would quite like to see the questionnaire that you will be sending out, and I think members probably would also. In addition to that, we obviously would like to see you again before too long, and I'm wondering, please, if you could return on the 4th of January with an update at our first meeting of the new year. And about that time, that will be before the consultation starts, I think possibly I will send an email to all members. Now, I'm speaking on behalf of myself here. I'm not including all members and insulting them. But I know we all have busy lives, and we hear of a consultation starting and we think, oh, it's a long way away. It doesn't affect us. But in actual fact, we are one of the best people to get this out into the community. I mean, I, for instance, have 23 parish councils to attend. I can take this to every parish council who are in the rural area and say, this does affect you. You may think you live a long way away, but when you want to go to Queen's or to City, this is going to affect you. So I think perhaps if I send an email to all members around the time we next see you and point it out that they can be the instrument to take this to their town councils, parish councils, groups that they belong, anything, and really waken people up and realise that there is a consultation out there that they need to be a part of. Otherwise, it will happen, and anything they don't like, it's too late. So my intention is to do that in the new year, and I would ask, please, that you return in January with an update of where you are. And if we could see the consultation questionnaire or whatever it is that you're sending out, then I think members will know what you're actually talking about. And possibly early new year, I don't know, because we've got 1 or 2 visits planned, but 1 or 2 people may just like to have a look at and come in and see whereabouts you're thinking of moving things to, or et cetera, et cetera. Leave it sort of fluid that we can do that. So thank you very much. Thank you very much to you all for your time. And again, I'm sorry that we had a late start. We're now discussing the ambulance service. So you two go together really, don't you? Thank you. Thank you very much, all of you. Grateful to you. Thank you. Bye-bye now. Thank you, Sarah. Well, thank you, gentlemen, and welcome. Again, apologies for running late. Can I introduce to the committee, please, Richard Henderson, who's Chief Executive of the East Midlands Ambulance Service, and Greg Cox, who's the General Manager for the East Midlands Ambulance Service for Nottinghamshire. Yeah. So, gentlemen, you have a presentation?
Richard, could you use your microphone, please? Just punch the button at the bottom or turn red at the top. There you go.
Apologies. Can you all hear me okay now? So, good afternoon. I'm Richard Henderson. This is Greg Cox. I do have a presentation which has been prepared, and it's a brief kind of canter through as to where we are from an East Midlands Ambulance Service perspective. A bit of an update from response to COVID. Talking a bit about our strategic direction. I'm conscious that I haven't had the opportunity to meet many of you previously. So at the end of the presentation, I've allowed some time for us just to talk through some more kind of general questions, if that's acceptable.
Yeah, just because we are running late, just so that you know, first, two things. We are broadcasting this through YouTube. And secondly, we have one or two members who have a 2 o'clock meeting. So we are trying to speed up, but it's been very difficult. We've had a tough one this morning.
No problem at all. And if it's okay with everyone then, with that basis, I'll go through the slide deck with a bit of pace and then sort of pause for questions at the end, if that's acceptable.
That's lovely. Thank you.
Thank you very much. So, if I could have the first slide, please. So, just a very brief outline as described. I'm going to cover off some elements around the strategy, some around performance and resourcing, and then around service improvement. As the Chief Executive of the Ambulance Service, my remit is very much for the whole of the region. That covers Lincolnshire, Leicestershire, Northamptonshire, Derbyshire, and Nottinghamshire. And then we'll have an opportunity to discuss some of the more kind of local pertinent data as well, if we may. So, next slide, please. So on this slide, what I've done is just to demonstrate at a high level where we are as an ambulance service. So at the top there we have the development of the vision, which is responding to patients' needs in the right way, developing our organisation to become outstanding for patients and staff, and collaborating to improve wider healthcare. And that's where we develop what we call the big three. And there's three key strap lines there of respond, develop, and collaborate. And under each of those main strategic objectives, we have a series of supporting strategies which have been developed in order to ultimately, with the aim and the objective, to deliver against our vision. And I am pleased to say that as an organisation, since I have presented on a number of occasions to the Health Scrutiny Committees, we have made some significant improvements. So when I think back to the journey, sort of in 2015-16, when I became the Chief Executive of the Trust, we were an organisation that was requiring significant improvement. We had a huge financial deficit and significant performance challenges. And we moved forward a number of years, and I'm pleased that our most recent CQC inspection, we were rated as good overall, and most importantly, I'm very proud to say outstanding for caring, and that's an absolute something I'm immensely proud to say. Not only that, we have seen some real significant improvements around our responsiveness and the time it takes to get to our patients. If we go on to the next slide, please. And apologies for the scale and the quality of this slide deck. I'm sure even on the screen it's. In fact, apologies, the way it's been presented on the screen is slightly different to the paper version, but there's there should be on the screen a series of bar charts which shows around performance as an organisation and across the categories of 1 to 4, and that is high level at a trust level. So if we can, I'm going to move on to.
So Richard, because it was too small and legible, right. There are a series of slides for each graph, so each one you want to look at, I can go.
Yeah, if I may then, on that basis, could I just ask that we skip through each of the bar charts, and I'll take questions at the end on those ones, and we'll go to the one which is around Nottinghamshire. Thank you very much. The reason for showing this table here is just demonstrating through 2020 to 21, it shows the level of ambulance performance in Nottinghamshire. So the category 1 mean standard, of which the standard required is 7 minutes, the performance within Nottinghamshire was 6 minutes and 34 seconds. So we exceeded the required standard. And for category 1, that is for patients whose life is in immediate threat. So as an example, that would be cardiac or respiratory arrest. At the 90th percentile of requirement, where you have to get to 90% of your patients within 15 minutes, we actually got there in 11 minutes and 21 seconds. So again, far in excess of the required national standard. When we get to the category 2 standard, which is an emergency standard, the requirement is an 18-minute standard. As you can see on the chart there, we were just over 20 minutes, the mean average, and the 90th percentile of 42 minutes against the 40-minute standard. So it's clearly a few areas where we have to make some additional improvements there. What I would say from a category 1 standard, some of those metrics are among some of the highest levels of performance of the ambulance sector. And when we compare ourselves against other peer counties and services. So I am very pleased around the improvements we've made within the division of Nottinghamshire. If I could just go on to the next slide, please. Again, what this slide is intended to do is just demonstrate around how we see a comparison between activity levels and conveyance. What we're trying to do as an ambulance service is, whilst it's absolutely imperative that we get the right type of response to our patients, there are equally times where sometimes patients require an alternative level of response. That may be they're dealt with over the telephone, or they're dealt with an alternative type of response. And sometimes we respond to patients and the patient is actually either left in their home address or referred to an alternative care provider. And the reason why I'm showing this chart here is to demonstrate that what we are seeing, despite a real growth in activity, we're actually conveying proportionately less patients to hospital. So when we talk about pressures on the acute trust and the emergency departments, we are very pleased to be able to demonstrate we are either leaving more patients in the community in the right place or responding to them in alternative ways. And that's a real positive for our patients. And there's a variety of reasons for that behind that. Some of that is around how, as a system, we've worked very closely with the broader NHS to develop robust pathways. Some of that is around our increasing and improving skill mix of paramedics on ambulances and our ability to access pathways and refer patients to alternative providers. And some of the level of activity that we have seen has been as a result of patients coming into the 999 system who may have been better served or more appropriately served in an alternative means. So sometimes that's through 111. Some of that may be through primary care, or indeed some of that may be through self-care or other types of routes. So the purpose of that chart was to demonstrate, again, another positive trend. If I may, the next slide, please. The next slide, what I have done on this slide is just demonstrating, comparing some activity trends, just to give a sense of some of the real increasing and improving levels of challenge that the ambulance services faces as a result of changing demands. I've compared May 19 and May 21 here. The reason being, last year and during the response to COVID, we saw some real changes to the way demands were presented to the ambulance service. And as many healthcare providers will tell you the same, that provision and call volumes were changed and kind of booked a lot of the national trends and normal trends that we would see. I will explain just a few of the definitions on this one, and apologies, some of the acronyms are not always very clear. So the one that says May 19, May 21, where it says HAT, is actually hear and treat. So that's where we have dealt with people over the telephone and not had a physical response to them. And you can see been a 48% improvement in patients being dealt with over the telephone. The see and treat, again, a significant growth in the number of people who have been, when we say see and treat, that's where an ambulance response has gone to a patient and that patient has been left in their home environment. And despite all of that, the see, treat and convey to the ED, the emergency department, we've actually seen an absolute reduction. The non-EDs, where a patient would be taken to an alternative care setting, so other than A&E, that may be an urgent care centre or a walk-in centre, for example. And then the next column shows around the actual growth. So when we compare May 2019 and May 2021, we've seen just short of 13% growth in demand in Nottinghamshire, within EMAS for ambulance services. And the final column there is around auto 111 calls. And this is where people have accessed the 111 system. And if you require a clinical assessment through 111 and you're unable to be assessed or triaged within a 30-minute time window, that call will automatically come across to the ambulance service. And as you can see from that metric there, a significant growth in demand from the 111 to 999 disposition. We, within the East Midlands, do not provide the 111 service. That's provided by Derbyshire Health United DHU, who provide a very good service. But what this demonstrates is where there is despite their increasing demands, there is a real increase in position of activity coming across to the ambulance service. And then the next column down is the same data set, but comparing June 19 and June 21. So you can see some very similar trends to what I described in the first section. But again, the one that I am really pleased to focus on is that around see, treat and convey to ED. Despite such significant growth in activity, we are actually proportionally taking less patients to the hospital, which is good to see. If I could go on to the next slide, please. So this slide is just around operational resource within the ambulance service. I don't intend to spend a lot of time on this slide, but the one thing I would say, both locally from a Nottinghamshire perspective, and Greg would be able to answer any specific Nottinghamshire questions, but as a trust, I'm really proud of the level of response that the ambulance service gave to the community during the response to COVID. As you may imagine, an extremely tough time for the ambulance service, not only from the demands that we faced, but the pressures on each and every one of our staff and the workforce, people from taking the 999 calls to responding to patients within the community, having to wear all of the complicated levels of PPE in such trying situations was extremely tough. And what I'm really pleased to say is the workforce absolutely went above and beyond day in and day out. I'm very proud of the level of service that was provided to the community, and it was demonstrated within the statistics of how we delivered and responded to those patients. So if I can just go on to the final slide, please. So this final slide is just around other areas of improvement, and three component parts. One is around clinical improvement. So what we have done within the organisation, we've been introducing a role of what we call a specialist practitioner. So this is an enhanced clinical role where our responders in those roles are able to respond to patients with differing clinical needs. So sometimes these may be with complex care needs. So aside from just core 999 routine calls, these may be patients who have got significant underlying health conditions and may require different levels of treatment within the community and can be treated in an alternative way than sending a double crewed ambulance. What we've also been doing is focusing around a refreshed cardiac arrest strategy. So this is around, as an example, increasing mass citizen CPR, increasing the numbers of community responders that we have available to the ambulance service, and so that if someone was to be in that unfortunate position of requiring an immediate ambulance response in cardiac arrest, that we can get a timely response to that patient. The next one around primary care crew information lookup. This is around using enhancement in digital technology to make sure that when we respond to a patient, we use the latest technology and access to patient records so that we can get a better clinical overview as to the underlying condition of that patient, and where people may have, for example, longer term conditions, it may be appropriate to not take them to an ED once you have that enhanced clinical knowledge of the patient's condition. Again, non-conveyance pathways speak for themselves around what we're doing more of and accessing more frequently, and then working with our primary care colleagues around how we can provide different type of rotational roles of paramedics into primary care where we're required to do so, and that's something which is in its early days of development. In around operational improvements, we're absolutely focusing on around efficiencies where we can make overall improvements in what we call our job cycle time. So this is around from receiving the call to responding to the patient, and ultimately, if we do convey that patient, to book and clear at the hospital. And that's an area that we want to absolutely maintain our focus. We're undertaking a restructure at the moment around our operations leadership. So this is around making sure that we have the right type of leadership in the right area, so that we have the appropriate support for our staff, and also we have the right level of strategic leadership and how we engage with systems and partners, and hence having Greg with me here today from a Nottinghamshire perspective. Another area, and many of you may have seen and heard around this, is around how we focus on hospital handover times, because one of the real challenges that we face at times of peak pressure is when we are required to respond to patients in a timely manner. So we use the example of a 7-minute response time for category 1 patients. And then we have examples where we take a patient to a hospital, and in some instances we've taken hours to be able to hand a patient over to the receiving hospital. Now, that is not only a really poor experience for that patient, it has a very serious impact on our ability to then respond to further calls within the community. And that's something which we as an ambulance service and the wider health system are absolutely maintaining the focus on, to make sure that we can see some clear, demonstrable improvements and changes in that area. And then, of course, in this section, we talk about post-COVID-19 recovery, and we sometimes talk as though COVID-19 has gone away. We absolutely know it hasn't, and the demands on healthcare are still very significant and continue to do so. We talk about winter planning. I think at the stage we're in at the moment, there's a real blur in between winter pressures and current pressures, because the reality is we're immensely busy every day, and there is no sort of clear defined line between current and winter planning. The reality is we're dealing with significant demand day in and day out, and we're having to respond accordingly. And then the final element around organisational improvement. Some of this is on the back of responding to COVID and our learning. There's no surprise that, like many organisations, the majority of our non-patient facing and non-core operational staff undertook remote working and home working roles. That in many ways worked really effectively, and it gave us an opportunity to start doing things in a different way. So what we have done is we changed the makeup of our control room, where our emergency call takers and dispatchers operate, and we spread them around the sort of the main HQ building, which is in Nottingham, and we have a secondary control site at Lincoln, and we're going to continue with that way of working for the foreseeable future. So it's allowed us to do things in a slightly different way. That's understandably linking to continuation of flexible working arrangements with our wider workforce. The bit about digital strategy investments, absolutely key for future developments, is around how we focus on the digital agenda. We've received some significant investment to enable us to roll out personal issue iPads to all of our frontline staff. So that's going to allow them to have access to clinical records of patients, access to other types of clinical records, and, for example, training materials, all on personal issue devices. And that's something which we're currently in the process of rolling out. And that's something I'm really pleased to see. And then the final area on this slide deck is around 111 and 999 further collaboration. As I spoke earlier in the presentation, there is a clear challenge between the levels of activity that go in and move across to the 999 service. We need to be able to work better together. So for two aspects, one is that to make sure that we get the right response to the patient first time, and secondly, so that the experience of the patient when they come into either the 999 or the 111 system is a seamless process and it's effective and their needs are met. And that's something I'm really keen for us to be able to improve and increase our focus upon. So at that stage, I'm going to pause with the intention of giving time for comments and questions, and take any questions at that stage, if that's okay.
Thank you very much. That
Thank you.
was very interesting. Thank you. I'm glad you referred to the time that you have to wait when you get to the hospital before you can hand over to the hospital to take the patient, because clearly that has an impact on your ability to go out and pick up another patient or attend to another patient. How are you actually able to alter that without the hospital making it better for you? Have they agreed to do that?
So, yeah, absolutely. I am pleased to say in Nottinghamshire, so from Sherwood Forest and Nottingham University Hospitals, we don't have significant challenges around hospital handover delays, and where we have had some real peak challenges has usually been as a result of either sudden patient demand or flow from the emergency department. And as a system, we tend to be able to very effectively, very rapidly address those underlying issues. As a regional service, we have had some real challenges at some of our hospitals, and they're things which we continue to work with our NHS Improvement and England colleagues, as well as those acute trusts. Unfortunately, the net impact of that can have an impact on a localised service. So, for example, if in Leicestershire we were under significant pressures and we were unable to hand our patients over. There may be times where ambulances from Nottinghamshire have had to respond into Leicestershire where patients have called 999. So that's the unintended consequence of a problem in another county. So that's something why it's a very real significant issue and we have to keep that focused on the agenda. I'm certainly not in a position where I'm blaming any aspect of the health system. It's just a reality of the pressures that we face. But for us as an ambulance service, our responsibility has absolutely got to be that patient, either in the back of the ambulance or the patient in the community where their needs have not yet been met, who often are at a much greater risk. But yeah, you're absolutely right. It is a real challenge.
Thank you. Right, members, here's your opportunity. Councillor Wilmot.
Chair. My first question, as somebody who represents a rural part of Nottinghamshire, could you tell me if there's been any work on response times within the rural areas of Nottinghamshire like Jacksdale, Selston and Underwood? And is it possible to have specific performance information for rural areas compared to more urban areas of the county? And could a report be brought back to this committee at least twice a year, if possible, to track performance of the EMS in these areas? I wonder if that was a possibility. Now, on other questions, you say that you're out there in 7 minutes, which is tremendous. You must have a helicopter to perform. I think I know the answer, but I want to know how you manage that so easily, because obviously all the ambulance vehicles won't be at the ambulance station, and they'll be all over. Do you have specific areas where you put them for just to make sure that you meet that times? I'd like to know about the assaults that you have. What sort of percentage of that does that happen on the ambulance drivers and the ambulance staff over a 12-month period? And the percentage of accidents that your vehicles have, could you give me any information on that? I mean, what sort of percentage are involved in serious accidents? And as far as the flexible working is concerned, I'd like to know a little bit more about how you deal with childcare and so forth for the ambulance people that drives, and how flexible are you? Because very often if the time is at the end of somebody's time and you're out there doing some problem, what's the problem with the child picking up the child from school and things like that? How do you combat that? Thank you very much, Chair.
Thank you very much. A series of questions within that. Some, if I may, some of the actual statistics. Absolutely, we can supply that kind of information, and things like, for example, percentage of accidents. I don't have that to hand, but we can absolutely supply that kind of information. And apologies for today's slide deck. I've kind of kept it high level, but for the future reports, we absolutely can keep that tailored to local need. In relation to the question about performance standards and responding to patients, there's a variety of ways that we do that. So some of that is around how we can ring fence certain types of resources. So that may be, for example, a paramedic in a fast response car, so that they're able to respond to those critically ill patients, those category 1 patients. Other examples will be where we use the fantastic network of community first responders. So they are people who have got enhanced levels of training, and there are different type of schemes. What they have access to defibrillators and other appropriate equipment. We will, in some areas, for example, work with the fire service around community first responders. So a variety of reasons as to how we can get to those patients very quickly. You're absolutely right in your observation that the ambulance service, given the levels of demand that we face, it's a very complex set of moving resources around to meet demand. We don't traditionally have the ability to be able to respond from the local ambulance station to the local community because the vehicles are often out in other areas. I'd like to say that in some instances you may see ambulance vehicles parked in the community at the side of the road. That, unfortunately, is probably a slight thing of the past at the moment, given the pressures that we face. We don't have that degree of sort of flexibility, but it's very much a complex case of moving resources to meet demand. In relation to the more rural communities, again, this is where we put enhancements in place around how we can work with local schemes, local responder schemes, and also we're trying to move the resources into those areas of peak demand. Your question around getting staff off on time, that's really challenging, and by the nature of the type of service that we deliver, if an ambulance crew is out on an emergency call, we have to allow them to finish that emergency call and hand the patient over at the hospital if that's where they've gone to. And that's another example why it's imperative that we get the patients handed over in a timely manner, because that vehicle also may then be required for another crew when they respond back to their base. We have lots of flexible working arrangements in place within the organisation for both operational and non-operational staff, so people can work in differing locations, they can work flexible types of hours, and we have to make adjustments to be able to support staff to work different forms of operational shift patterns. That sometimes can have its complications, but I'd like to say that we will work closely with staff to, where possible, facilitate that. The assaults on staff, this is absolutely an area where it's unacceptable that ambulance staff get assaulted, where they're simply doing their job that they've chosen to do. When they respond to emergency calls and they're subject to be that verbal or physical violence, any incident is unacceptable. But sadly, there have been occasions where we've had far too many. One of the examples you may have seen in the media recently is we've rolled out or commenced the rollout of body-worn video cameras, and that is again, sometimes it's a sad state that we have to get into a position where we have to have such types of technology available for staff to wear, but it's to demonstrate not only as a visible deterrent, but as an organisation, if anybody is exposed to be physical or verbal aggression, we will take a zero tolerance to that, and we will pursue prosecutions of those people who choose to assault or abuse emergency service workers in the line of their duty. So I would like to see the body cameras rolled out more frequently, and I would like to see us in a position where we could ultimately get to a place where there is zero attacks or assaults on our staff. And your final question is, again, just around statistics. We'll make sure for future reporting that's available to you.
Thank you very much. Councillor Gowland. Councillor Gowland, can you put on?
Sorry. Can I ask that in future the graphs could not just show the 90th centile, but maybe the absolute max, or the 99th centile? Because anecdotally, of course, we always hear of the worst case scenario, and we appreciate these numbers are really good, and that there's always we hear the worst case, but it would be good to put that into context as well, and that would probably address some of the rural issues too. Thank you.
Thank you.
Do you need to comment on that? I don't think you do.
No, I take that point.
Anybody else while you've got the opportunity? Well, I think in general, I think you're having a lot of success. Clearly, we always hear of the cases where people are sitting on the roadside waiting for an ambulance, and I only heard of one yesterday. But generally speaking, you have a very difficult job to do. And if we travel around Nottinghamshire, we can't complain, but we've got a lot of roadworks which don't help. And I think generally speaking, you're doing pretty well. I know that Councillor Wilmot asked for you to come or report back twice a year. I think reasonably, I would suggest once a year. What do other members feel? Once a year is adequate? Right, I see a load of nods. So can we ask you, please, if you would come back in a year and bring us more details of how successful you've been over the last 12 months?
Thank you very much. With pleasure. Thank you for your
months.
time today. Thank you very much.
And thank you very much to you both for coming, and my apologies again for us running late.
No, thank you, and apologies. I don't know if there was anything final for Greg, and I'm conscious I've done all the talking, and I apologise for that.
No, do you have anything to say, Greg, that hasn't already been said?
No, not at all. I think I'm quite happy to leave it there.
I like it. I tell you what, next time it's your turn.
Okay, thank you.
Right, thank you, gentlemen. And without keeping members back any longer, I must apologise. This has been a very long meeting, but we have really got some solid subjects on this agenda to look through. And can I tell you that we return on the 7th of September, and we will be looking at access to primary care and the crisis mental health services, and they will be both on the agenda, plus the fact. Pardon? And we've got, thank you, gentlemen. And of course, we've got Bassett Law Mental Hospital returning. So I think it's a case soon, members, of bringing sandwiches. Thank you very much. Could we have the live stream turned off? Thank you.